hello. Oh my God. Can you guys believe it? It's the last day of the webinar. Today's webinar is going to be special. It's not like any other webinar that you've had, during this 4-week crash course. I'm telling you, you guys gonna love it. This webinar is to prove a point, actually, and um, you will thank me later after you pass your NCLEX. Trust me. I'm gonna group everything together in one webinar. We're gonna go over the slides. There will be no interaction from you guys. It's just me talking, so you will just be listening, and we'll go over my slides. And you don't want to miss, by the end of this webinar, I have a huge surprise for you guys. This is something that will provide you tons of value for your NCLEX. So just that extra mile, whoever takes that extra mile is gonna thank me later after you pass your NCLEX. Alrighty, so we're gonna start. I'm gonna share my slides. Where are my slides? Oh, there you go. Alrighty, so as always, thank you for giving me this opportunity to make a difference in your life. Welcome to the live NCLEX webinar, the ultimate algorithm to pass your NCLEX on your very next attempt. So as I said on day one, so you've got the live webinar, which is you're attending right now. You've got the video records. A lot of you got so much value from those. The notes, not all of you like read the notes, which I understand, but if you have deficit in nursing content and you want to get back to definitions, just go back to the nursing notes. There's tons of value over there. And podcast, a lot of you guys didn't take advantage of the podcast, which I wish you would. I would like you to listen to day 20 over and over again, over the podcast and the video record. Okay, just make sure you listen to it over and over and over. Day 20 is it's so important. And test your knowledge on the weekend. See that you guys have done an amazing job. Amazing job. You've learned a lot. You came a very long way, and I bet every single one of you will pass their NCLEX. And first off, you're gonna make yourself proud, but then you'll make me proud, and all your colleagues, you'll make them proud. You'll make your family proud. And next time we talk, hey, listen, you're gonna be on this wall of testimonials, wall of fame, and we're gonna share this experience. Trust me, it's gonna be epic. I'm gonna see the smile on your face. I'm gonna see how happy you are. You will share with us, with everyone, with the world, like your future, your career. Like the limit is the horizon, right? Alrighty. So the road to become an alpha slice is bumpy. I've been saying this over and over again, but welcome to your NCLEX RN intensive webinar course. This is day 20, final day, and we're gonna start with the first slide, and we're gonna go over all the slides. So you guys pay huge attention to what's going on. Try to keep up. This is gonna be a fast pace. Try to keep up. If you have questions by the end of the webinar today, or you can text me on WhatsApp and send me your questions, or email me your questions, and I'll make sure that I will answer every single one of them. But for this webinar, I just want you to keep the pace, like tuck 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 tuck. I want you to keep the pace and you will see what are the areas that you need to review, what are the areas that you have deficit in, and what are the strong points that you already mastered. Okay, so moving on. Staff management. How do you deal with conflicts with staff members? Notify your supervisor, right? Or ignore your colleagues, or confrontation, or deal with them later. In such situation, you need to ask yourself the following: is this legal? Is what happening is legal? If yes, it is legal, then follow the chain of command and notify your supervisor. If it's not legal, then you gotta ask yourself, is this causing harm to the patient, psychological harm or physiological harm? If yes, then you need to confront that nurse. You need to talk to them, take action, and stop that harm that has been caused to the patient. If there's no harm caused, then you need to ask yourself a question: is this appropriate? If yes, it's appropriate, then you can deal with it later. If this inappropriate, then yes, you can deal with this later. It doesn't have to be addressed right now. But there's another question that might arise: what if the situation is harmful and illegal, what are you gonna do? Yes, you're gonna confront the nurse or whoever is doing the harmful thing, and then you're gonna report it to your direct supervisor. Prioritization. We've been saying this over and over again. Age and gender are not of high importance. Diagnosis and scenario. Keep in mind, acute overweighs chronic. Acute overweighs chronic. Stable or actually unstable overweighs stable. Fresh post-op, less than 12 hours overweighs any other situation like medical or surgical scenario. So what are the stable situations? We have less than 12 hours, stable, greater than 12 hours post-operation, chronic diseases, slightly off lab values, local spinal anesthesia, expressions like the patient is for discharge or the patient has been admitted for more than 24 hours, expected signs and symptoms, and then the unstable stuff, you got completely the opposite. So less than 12 hours post-op, acute episodes, critically abnormal values, general anesthesia, not ready for discharge, newly admitted less than 24 hours, unexpected signs and symptoms. But there are things that are always unstable no matter what. What are they? Yes, prioritization, pyrexia, fever of more than 104, witnessed arrest, hemorrhage, and I'm talking about internal hemorrhage, and then hypoglycemia. If we want to talk about vital organs from the highest priority to the lowest priority, we're going to talk about the brain, lungs, heart, liver, kidneys, pancreas, and intestines. Now we're going to move to antihypertensive. Remember those guys? There are a few families you need to master. Just master them. Calcium channel blockers. All right, first we're going to start actually with digoxin. So digoxin, which is lanoxin as well, ACE inhibitors, everything that ends with pril. You got beta blockers that ends with lol, and then you've got calcium channel blockers that ends with dipene or ZEM, like diltiazem, which is an IV calcium channel blocker, or verapamil. So calcium channel blockers, they are consider them as sedation to the heart. They slow the heart rate, so they have negative effect. It can be negative inotrope, chronotrope, or dromotrope. So inotrope is contractility. Chronotrope is rate. Dromotrope is conductivity. Bear in mind, calcium channel blockers do not work directly on the heart. They work on the peripheral arteries and vessels, and they decrease the oxygen demand on the heart. What do we use calcium channel blockers for? Or antihypertensives in general? We use them, remember, 3 antis: antihypertensive, anti-angina, anti-arterial, anti-arrhythmia, or anti-arterial arrhythmia, and SVTs. What are the most popular side effects to calcium channel blockers and antihypertensives in general are headache and hypotension. Other antihypertensives, we said digoxin. Signs and symptoms that are hallmarks for digoxin are halos, blurred vision, green vision, yellow vision, any kind of vision disorder. Just think of digoxin toxicity. ACE inhibitors, dry cough or non-productive cough. Beta blockers, they do not really have any specific side effect. They lower the heart rate because they block the beta receptors. Okay, all of them have the same indication side effects as calcium channel blockers. So indication, we said the 3 antis, side effects, hypotension, and headache. All right. So indication for those in particular cases, patients who have cardiac history, you give them calcium channel blockers. Patients who do not have a cardiac history, you give them beta blockers. Patients who have kidney problems, you give them ACE inhibitors. And if nothing works, it's always digoxin, the magic drug. All right, we're gonna talk about diabetes insipidus real quick. It is a deficiency in the ADH hormone, antidiuretic hormone. Basically, when you want to think about diabetes insipidus, you want to think about ADH. ADH is excreted by the posterior pituitary. You want to think of ADH as the doorkeeper or the gatekeeper of the kidney. So it stands right there. I'm gonna show you where. It stands right there, and it's a doorkeeper. So if it's present, then it will not allow the kidney to lose water. But if it's not present, which is in this case, then the kidney will lose a lot of water. So 2 problems could be there. The problem could be the ADH deficiency, which could be central origin, and then you will not have ADH to stand on the gate. But the problem could be also from the kidney, where there is ADH, but the kidney is resistant to that ADH. So even though there's ADH, but the receptors are not taking it. Again, I want you to know that aldosterone is also secreted by the adrenal gland. This is not related to diabetes insipidus, but this has the same function as the ADH. So it is excreted by the adrenal cortex to the kidney. It's also considered as gatekeeper. All right. So side effects of diabetes insipidus. You've got 3 side effects. I call them PPD, just like the tests for tuberculosis: polydipsia, polyuria, and dehydration. Just keep them in mind. Now, as I said on the first day, there are a lot of things that you need to Google, right? So let us say telangiectasia or stroke bites. You just Google it, look at the images at first, you see what the disorder is. If the images could not help you, then you click that all button right there. Let me show you where it is. You click that all button, and then you read, definitions. And if that didn't help you, then you go through websites. All right. But my best bet is that Google will answer your questions right away, especially from the images. Let us say Mongolian spots. You don't know what Mongolian spots is. You just Google it, and then that image will stick in your head forever. Now we're going to talk about delegation. Nursing assistive personnel. What do they do? Well, I know what they do not do. There are things that I do not delegate to a nurse assistive personnel, which are, okay, documentation. They only document what they do, period. Giving PO medication, I do not ask them to do that. Assessments, they do not do assessments unless they are vital signs or acute checks. Treatments, never. Never delegate first time of anything. Enemas are okay, even though they include glycerin, but they are okay. Catheterization only in crisis situation of low staff. And then you can delegate ADLs, of course, they can do that. We're going to talk a little bit about drug levels. Drug levels, we're going to talk about peak and trough. And there's a mistake here in this slide. So the peak are determined by the route of administration. The trough, it's always 30 minutes before giving the drug. Okay, peak determined by the route of administration. Trough is always 30 minutes before giving the drug. So peak, you draw it depending on the drug that you're given, right? It depends on the route. So if it's IV, it's one thing. If it's sublingual, one thing. If it's IM, it's another thing. So it does not matter what medication you're taking level for. It could be amikacin, vancomycin, etc. All drugs are the same. What's important is that you need the route of administration. So for sublingual, 5 to 10 minutes after the drug is given. So you stand at the bedside, you give the drug, you stay at the bedside, and then you draw your labs, you draw your peak at 5 to 10 minutes after you give the drug. IV, 15 to 30 minutes after. What happened? Alright, IV, it's 15 to 30 minutes after drug is administered. So what we mean is after the drug is finished. So when the drug is finished, you wait 15 to 30 minutes and then you take the peak. IM, 30 to 60 minutes after administration of the drug. Remember, PCAs, patient control anesthesia, are always locked at 15 minutes because the peak of IV are from 15 to 30 minutes. So before allowing the patient to take another dose of painkiller or narcotics, fentanyl or morphine or whatever, you need to allow 15 minutes until the drug peaks and it gives its effect. Now we're going to talk a little bit about ABGs. Hey, you love ABGs, right? Normal values: pH 7.35, 7.45, CO2 35 to 45, HCO3 22 to 26, PaO2 80 to 100, SpO2 actually 95 to 100%. There is one word you need to remember, which is ROME. Respiratory, opposite, metabolic, equal, right? The only two components of those normal values of high importance are pH and CO2. pH and CO2, opposite direction, that means it's respiratory. Same direction, it's metabolic. That's why it's ROME. Respiratory, opposite, metabolic, equal. So if pH and CO2 are going in opposite direction, then that's respiratory. If they're going in equal direction or same direction, they're metabolic. Let's give an example. I'm going to put the normal values up there. All right, so let's say pH equals 7.29, CO2 equals 33. So pH is going down, right? CO2 is going down. Both are going in the same direction, equal direction. That means it's metabolic, right? Is it acidosis or alkalosis? The pH is going down. It's below normal. That's acidosis, right? So metabolic acidosis. There you go. Let's give another example. pH equals 7.29. CO2 equals 47. pH is going down. CO2 is going up. Opposite directions. That means respiratory. What about the pH? Is it acidotic or alkalotic? Well, 7.29, it's acidotic, right? Already. So now you know. Let's talk about a little bit about signs and symptoms. Where so there's a general rule that you need to understand. Where the pH moves, so the patient moves, except for the potassium. What does that mean? If the pH is going up, then the patient, all his symptoms, signs and symptoms are excitatory. Except for the potassium, it will go down. But if the pH is down, which is acidotic, then the patient moves down, then everything is inhibitory except for the potassium. The patient is having hyperkalemia. One thing I want you to keep in mind, and we're going to talk in the next slide about some signs and symptoms, but if you see Kussmaul respiration in the options, then choose metabolic acidosis because that patient is a patient who is experiencing DKA. Kussmaul breathing is a deep and labored breathing pattern. So what are the causes of these disorders? The causes are, let's start with metabolic acidosis. Well, you have shock, you have DKA, you have drug poisoning, respiratory acidosis, you've got two of them. You've got COPD and you've got asthma. Respiratory alkalosis, you only got one, which is panic attack. Patient is hyperventilating CO2, he's retaining CO2. So he's washing out a lot of CO2 actually. So you ask the patient to breathe slower to retain CO2. Sometimes we give them a paper bag to breathe inside the paper bag. Metabolic alkalosis, well, you've got 5 options. Could be vomiting, hypovolemia, diuretic use, gastrointestinal suctioning, where you put the NG tube on intermittent or continuous suctioning, and then you've got hypokalemia. Now we're going to talk about the algorithm to figure out the cause of the disorder. So you're gonna look at the scenario. Is the scenario talking about the lung? If yes, it's talking about the lung, then it's respiratory. So if it's respiratory, you've got 2 questions. Is the patient overventilating? If yes, he's overventilating, then you've got respiratory alkalosis. And what is that? Examples: panic attack. That's the only example. So let's say the patient is underventilating. What is the cause? Respiratory acidosis. I mean, so the abnormal is respiratory acidosis. What is the cause? It's COPD or asthma. Let's say the scenario is not lung, then it's metabolic, right? So you always think of you always look for those options that cause metabolic alkalosis, which are vomiting, suctioning, hypovolemia, diuretic use, and hypokalemia. Anything that's not included in this slide, you just call it metabolic acidosis. All right. So things to keep in mind about burns. Let's say a few pro tips. 1st degree burns are red and have no vesicles. 2nd degree burn, they are red, wet, shiny, and have vesicles. 3rd degree burns are white, dry, and hard. Those patients with 3rd degree burn, they do not feel pain because the nociceptors, which are the pain receptors, are only found in the epidermis and dermis. 3rd degree burns are subcutaneous tissue. They could get to the muscle and the bone. So there are only three degrees of burns: 1st, 2nd, and 3rd. All right. Rule of 9s to calculate the percentage of the burn on the human body. We'll talk about this in the 2nd slide. I want to talk about immunization. Tetanus toxoid. You give it to the patient if the patient had a previous immunization with tetanus. If the patient did not have a previous immunization with tetanus, you give tetanus antitoxin. In emergency situations where the patient is at home and they're calling over the phone and they're saying that they had a burn or something, if it's severe, just ask them to put a clean and dry cloth over the burn, and you do not remove that when it adheres to the burn. You just bring them to the ER, try to wash that piece of cloth, try to take it off as gentle as possible, but if you couldn't, then never mind. When there is an eschar, it will be removed right away. So the rule of 9 that we're talking about is 9% everywhere. So you can calculate the percentage of the burn using the rule of 9 as shown in the picture. So now we talked about delegation for the NAP. Let's talk about delegation of the LPN. What are the things that you do not want to delegate? Admission assessments or transfers, right? Hanging or mixing IV medication. Hanging IV bags with electrolytes. They may hang plain IV bags, but not bags with electrolytes like potassium and magnesium. LPNs can give IV medication under supervision of the RN, okay? IV push medication, no, that's a no-no. Starting a peripheral IV, that's a no. Can maintain and discontinue IVs and apply a Band-Aid, but they cannot start a peripheral IV. Blood administration, that's a no. Central lines and anything that has to do with central lines, we don't delegate it to them. A plan of care, we don't delegate it to them. They can implement the plan of care, but initiation of plan of care is the RN's job. Plan, teach patient, educate, they cannot do, but they can reinforce it. Unstable patients, you do not give them to the LPN. First of anything, verbal orders, you do not give. We've got vaccination schedules for adults and elderly. It's as shown in the picture. I would like you to print this out and hang it on your study wall and look at it every now and then, okay? Drug addiction in newborns. So if a newborn is within the first 24 hours, I want you to think of intoxication. So if there are two options in the question, they're talking about intoxication and withdrawal, then you choose intoxication. More than 24 hours, you consider withdrawal. Mothers addicted to a medication, which is pain medication, Equalin, newborn will experience withdrawal symptoms 24 hours after birth. Usually select all that apply questions. These form of like drug addiction in newborn come in a select all of that apply questions. So make sure you are aware of withdrawal symptoms. We're going to talk about risk for seizures, fever, tremors, startle reflex, which is the motor reflex as well, hyperactive reflexes, respiratory depression, sweating, strong high-pitched cry, or excessive cry. All right. Now we're gonna move to psychotic drugs. All right. You need to memorize those. All psychotic drugs cause hypotension and weight gain, except for Prozac, it causes weight loss. Zines, I like those zines. Phenothiazines, first generation typical antipsychotics, they are major tranquilizers. That's why they will have major side effects. And we're going to talk about them in the next slide. They are not a cure, they are to control symptoms. All right. Large doses control psychotic symptoms like delirium, hallucination, illusions, whatever. But small doses are used as antiemetics like promethazine or compazine. Decanoate for those non-compliant patients, it's a long-acting. Usually give it IM ventrogluteal muscle, which is the lateral femoral muscle, and you give it to the patient. It takes 1 month. So you schedule them back in the clinic in 1 month. So psychotic drugs, major tranquilizers, we're going to talk about side effects. As I said, major means a lot, so they have a lot of side effects. We're going to start with alphabetic disorders. A, anticholinergic effect, mainly dry mouth. B, blurred vision. C, constipation. D, drowsiness. E, extrapyramidal symptoms. F, photosensitivity. Skin burns, so you wear sunscreens, long sleeve, hat, stuff like that. But if the patient is having photophobia, then they wear sunglasses because the sun or the light will hurt their eyes. G is granulocytopenia, low granulocytes or low white blood cells. And again, the major nursing diagnosis that you need to focus on is risk for injury or fall, which is risk for safety in general. All right, benzodiazepines. You see I highlighted it in red, zip. They like to call them the zip. These are minor tranquilizers, so they have minor side effects, like smaller list of side effects. So they call them the zep. These are like Valium, which is the diazepam, lorazepam indication. What do we give them? We give them for alcohol withdrawal patients. We give them preoperatively for patients with anxiety. We give them as muscle relaxant. and we give them for status epilepticus. Status epilepticus is a very dangerous condition where the patient will be having seizures back to back without recovery to full consciousness. And you know, I like medical terminology because medical terminology will save your butt in your NCLEX, on your NCLEX. So lucidity is the recovery between two episodes of um, epileptic seizures, or yeah, epileptic seizures. So it's called lucidity. If you see that word in a question, then you know what they are talking about. Benzodiazepines, minor tranquilizers. So we said small list of side effects. We've got A, anticholinergics or dry mouth, B, blurred vision, C, constipation, D, drowsiness. They work very fast, 1 to 3 minutes, and they will be working right away. Do not take them for more than 4 to 6 weeks. Again, nursing diagnosis is risk for safety, right? Tricyclic antidepressants. So we have 4 drugs. We talked about them a lot during this webinar: Aventil, Desiril, Elavil, and Tofranil. Okay, so they take 4 to 6 weeks to start working, and you give this medication as a long or lifelong treatment. Okay, side effects. Since they are antidepressants, so we're gonna talk about A, B, C, D, and E, but the E is gonna be euphoria, because we want to make the patient happy because he's depressed. Okay, it's not extrapyramidal signs. So A, dry mouth; B, blurred vision; C, constipation; D, drowsiness; E, euphoria. Okay, and again, the same nursing diagnosis, which is risk for safety. We're gonna talk about monoamine oxidase inhibitors, or MOIs. They are antidepressants. Again, the E is euphoria, right? What are these medications? We call them the PAR-NAR-MAR. Parnate, Nardil, Marplan. Okay, so side effects, as we said, A is going to be dry mouth, B, blurred vision; C, constipation; D, drowsiness, and I don't think there is an E for MOIs. All right, so again, nursing diagnosis is risk for safety. So patient education is very important if they're taking MOIs, which is to prevent hypertensive crisis. Okay, whenever you think of MOIs, I want you to think of tyramine. So avoid all tyramine containing food. Um, there are food that patients do not need to avoid, like fruits, veggies, grains. They do not contain tyramine. There are some food that contain mild tyramine. The patient can eat them with caution, like avocado, banana, canned or dried fruit. Do not eat organ meat. Do not eat anything that has cured, smoked, dried meat or fish, such as sausages or salami, which is pepperoni, I believe. So any dairy products you cannot eat, aged cheese, yogurt you cannot eat, chocolate, and any caffeine beverages you cannot eat. Over-the-counter medication that has the word elixir in them, like Benadryl or any other medication you cannot eat. Now we're going to talk about lithium. Lithium, they give it to the mania stage in a bipolar disorder patient. So you only give it in mania, you don't give it in depression. This is the only drug that does not mess up neurotransmitters, which means that there are no side effects. There are side effects, but there are no like traditional side effects, the ABCDs. They got side effects, which are triple Ps: paresthesia, peeing, and pooing. Toxic effects: we've got seizures, metallic taste, severe diarrhea, heightened reflexes. What is the normal level of lithium? You bet it's 0.6 to 1.2, similar to what? Creatinine, yes. Serum levels of lithium above 2 mg per liter are toxic levels, okay? So we're going to talk about Prozac. Prozac and Zoloft, both are SSRIs. So we'll start with Prozac. SSRI, classic antidepressant. When I think of Prozac, I always have in mind the tricyclic antidepressants, okay? Similar to Elavil, it takes 4 to 6 weeks for them to start working, can be given as lifelong treatment. Side effects include A, dry mouth; B, blurred vision; C, constipation; D, drowsiness; and E, because it's an antidepressant, it's euphoria. One of the side effects, like the hallmark side effects of Prozac, is insomnia. So you give them before noontime, okay? And there's a risk for suicide, especially in young adults, when you change doses. We're going to talk about Haldol, which is the only antipsychotic drug that is safe for pregnant women. It is a major tranquilizer and lagdazines, first generation, typical antipsychotics. Side effects: A, dry mouth; B, blurred vision; C, constipation; D, drowsiness; E, extrapyramidal side effects; F, photosensitivity and photophobia; G, granulocytopenia, and they have risk for injury and falls. Haldol, which is the decanoate for those who are not compliant, and trust me, some pregnant women are not compliant. So Haldol has a very hallmark side effect, which is the neuroleptic malignant syndrome, especially when patients are overdosed. So when Haldol overdose, you need to watch out for NMS, a toxic life-threatening effect popular amongst young white men and elderly. So what you're looking for fatal, which is deadly hyperpyrexia. It's between 104 and 108. Do not mix it with extrapyramidal signs and symptoms, anxiety and tremors, because with NMS, you will also have anxiety and tremors. But what's going to differentiate it is fever. Always look for the fever, right? Clozapine is a second generation atypical major tranquilizers. When this drug first came out, they thought it's the magical drug because it doesn't have any signs and symptoms. So they used it to treat schizophrenia, and it meant to replace all the antipsychotic drugs. Basically, it didn't have any side effects, but later on they discovered it does. So other than the extrapyramidal side effects, it had severe granulocytopenia. Patients would go into neutropenia and they will not recover. That's why they stopped using it. Zoloft, which is an SSRI, just like the Prozac, it's an antidepressant similar to the Elavil. As we said, 4 to 6 weeks, a lifelong treatment. Side effects: we're going to talk about dry mouth, blurred vision, constipation, drowsiness, euphoria, because these are antidepressed, like these are depressed patients, and we want to make them happy. And you've got insomnia, just like Prozac. But Zoloft, you give it at 9 p.m. Don't ask me why. It's just like that. All right, so Zoloft has a lot of interactions actually, and you need to pay attention for those. So if your patient is on Zoloft, but at the same time he's taking Coumadin, so you need to watch out that PT and INR, because at one point that PT and INR will get low and you need to increase the dose. So you need to pay attention for that. On the other hand, St. John's worts, which is a herbal product used in a lot of antidepressant, products, over-the-counter products, and weight loss products. If you mix it with Zoloft, you get a side effect called serotonin syndrome. Signs and symptoms for serotonin syndrome are DDD and H. What concerns me is the H. The H is a severe headache due to hypertensive crisis, just like the one you see with MOIs. This is a serious hypertension. It can cause intracranial bleeding. It's blood pressure above 200, systolic blood pressure above 200. So the DDD are diaphoresis, dizziness, and down effect. We're going to talk about alcohol withdrawal. Oh, actually, we already talked about this, but let me see. Let's talk about the signs and symptoms. I think there's a couple more in this slide. So high-pitched cry, irritability, tremors, shaking, jittering. So different terminology: difficulty sleeping and settling, stuffed nose, sneezing, difficulty feeding due to sucking problems, tense, tight arms, legs and back, poor weight gain, vomiting and diarrhea. All right, now we're going to talk about labor and delivery. Signs of labor. What are the signs of labor? Regular contractions, frequent contractions, longer and stronger contractions. Definitions. There are medical terminology that I want you to learn, memorize, and master. Dilation is the opening of the cervix. Usually it's from 0 to 10 centimeters. Effacement is the thinning of the cervix, goes from thick to 100%. Station is the fetal presenting part to the mother's ischial spines. And we're going to see in the next slides what are the ischial spines. So if it's in the negative, we start -3, -2, -1, and we're going to see a slide. That means that the baby or the fetus is still above the ischial spines. If it passes the ischial spines, which is the 0 station, then we'll start counting in the positive. And then you've got the engagement, which is station 0. You say that the baby is engaged. The baby will be at the level of the ischial spines, and then the presentation. It depends on the body part that goes first in the patient's pelvis. So we're gonna talk about different presentations in this slide. So the lie of the baby or presentation of the baby, you've got the longitudinal lie, which is the breech position. We've got actually two longitudinal lies. We've got the breech position and we've got the vertex position. The breech is when the baby's bottom is engaging with the pelvis first, but the vertex position is when the baby's head is engaged with the pelvis first. Both of these positions, you've got the spine of the baby parallel to the spine of the mother. But if the patient is in the transverse lie, which is a shoulder presentation, then the spine of the baby is perpendicular to the mother's spine. Okay, let's move to that. So these are the highlighted in red. These are the ischial spines, and this is the fetal station. You can see at station 0 is where the ischial spine is. So we're going to talk about stages of labor. All right, stage 1, it has 3 phases actually. It has the latent, active, and transition, and we're going to talk about every single one of them. Stage 2 is actually the delivery of the baby. Stage 3 is the delivery of the placenta, and stage 4 is the recovery. So postpartum is actually 2 hours after the delivery of the placenta. All right, brief definitions, we're going to talk about them. Frequency of contraction, from the beginning of one contraction to the beginning of the next contraction. Duration of the contraction actually is from the start or beginning of one contraction to the end of the same contraction. Intensity, this is subjective according to the patient, how good she's handling the pain. Stage 1 of labor. All right, we said it has 3 phases. Phase 1, which is a latent phase, 0 to 4 centimeters, dilation of the cervix. Contractions are 5 to 30 minutes apart. It lasts 15 to 30 seconds. Phase 2, it's called the active phase. It's 5 to 7 centimeters. Contractions are 3 to 5 minutes apart, lasts 30 to 60 seconds. Phase 3 is the transition phase. The dilation of the cervix is from 8 to 10 centimeters. Contractions are 2 to 3 minutes apart, and it lasts 60 to 90 seconds. I want you to keep that in mind. If contractions are lasting more than 90 seconds or between contractions, 2 consecutive contractions are less than 2 minutes apart, then something is going wrong. All right, stage 2 of labor, we're going to talk about the sequence. How is the baby delivered? First, you deliver the head, then you suction the nose, then you check for the cord if it's around the neck. If it's around the neck, then you push the baby back a little bit and release the cord. And then you deliver the shoulders, then the body, then make sure that the baby is wearing an ID band before they leave the delivery room. This is very important. Stage 3 of labor, you've got the delivery of the placenta. Make sure placenta is intact. Immediate complication, because of fragments, they are retained inside the uterus. You've got hemorrhage complication. A later complication is infection, which is usually 48 to 72 hours after delivery of the placenta. So you want to make sure when you deliver the placenta, you make sure that you have 3 vessels. They should be 2 red vessels and 1 blue vessel, so 2 arteries and 1 vein. Stage 4 of labor, you've got the recovery stage. So that's when you need to monitor the fundus, you need to give Pitocin, the contraction of the uterus to stop bleeding. Postpartum, as we said, it starts 2 hours after delivery of the placenta. You always need to monitor vital signs. It's just like post any surgery. You need to monitor vital signs every 15 minutes, and what you're looking for is signs of shock. So you need to also check the fundus, palpate with one hand with your fingertips, try to see if that fundus is firm. If it's firm, you massage it. So if it's firm, you massage it. If it's not centered at the midline, then the patient has a urinary retention. So you ask the patient to go to the bathroom and void. If the patient is not able to void, then you catheterize the patient. After 24 hours postpartum, fundus should be at the umbilicus level. So we're going to talk about the colors of the discharge from the vagina. So they call them lochia. So pads for saturation. Excessive lochia or bleeding is saturating a pad 100% in 15 minutes or less. The normal is 1 pad every 1 hour. So you've got 3 colors. You've got the lochia rubra, which is red, occurs in the first 3 to 4 days after childbirth. You've got the lochia serosa. The lochia rubra gradually changes color to brown and then to yellow over a period of 1 week. And then you've got the lochia alba. The lochia alba is a whitish turbid fluid which drains from the vagina for about another 1 to 2 weeks. So you want the colors to go from red to brown to yellow to white. If they go from red to brown to yellow and then they go back to brown, then something wrong is going on. I just put this picture here to remind you of the wound drainage reservoir, or they call it JP drain. So this drain, you put it at a negative pressure and you close that lid. If it inflates right away, that means that there is a leak. You find the leak and you tape it. The purpose of it is to drain whatever is bleeding from the wound. You do not want accumulation of hematoma under the skin. And then you've got the Vaseline. It's also called petroleum jelly. Levodopa. If you remember, we give levodopa with Parkinson's disease patients, and it works on dopamine receptors. So a dopamine promoter, it can treat Parkinson's disease. So Parkinson's symptoms, including tremors, stiffness, slowness of movement, are caused by a lack of dopamine. Dopamine is a natural substance usually found in the brain. So what levodopa does is it's a class of medication that works by being converted to dopamine in the brain. Now we're going to highlight a little bit about air embolism. Air embolism, if it gets to the heart and the heart pumps it to somewhere else, it's gonna be catastrophic. So if it goes to the brain or it goes to the lungs, it's gonna cause major complications. So air embolism, signs and symptoms, you got breathing difficulty, chest pain, confusion are symptoms of air embolism. How do you treat it? So supportive care. You just put the patient either in Trendelenburg position on his back, or you put the patient on his left side, and you wait for 20 to 30 minutes until the embolus is buffered by the blood. So let's see. Treatment consists of supportive care. Treatment include hospital care, oxygen, removing the air from the heart, and a high pressure chamber. Okay, Trendelenburg position, so lying face up with the feet 15 to 30 degrees higher than the head. That will drive the thrombus towards the extremities. Hypophysectomy, which is the removal of the pituitary gland. A major side effect after this surgery is CSF leak. So CSF leak is a major complication after the surgery, and usually the leak comes from the nose or the mouth sometimes. So you need to be careful, assess for clear fluid on the pillow if the patient wakes up, or if it is in one of the questions, so you need to pay attention for it. So treatment for TB. Now we're talking about tuberculosis. What is the treatment of tuberculosis? It's 4 drugs, 4 antibiotics, isoniazid, rifampicin, pyrazinamide, and ethambutol. Okay, 4 drugs. Memorize them. Patient is considered cured after 6 months, but usually after a couple of days, the patient will be asymptomatic. Okay, not a couple of days, but maybe 3 to 5 days. Side effects of the treatment: you've got fever for 3 or more days, pain in the lower abdomen, itchiness or rash. You've got nausea, vomiting, and low appetite. You've got yellowish skin or yellowish eyes, dark or brown urine, and let me throw this out there: orange urine with rifampicin. And then you've got fatigue, of course, tingling, burning, and numbness of the hands and feet, which is peripheral neuralgia, right? Patients who have done orthopedic surgery, they use something called trapezius or trapeze. That trapeze will help them scoot up or scoot down, or move to the side of the bed when they have hip fractures or total hip replacement or any fracture or any orthopedic OR. Now we're going to talk about barium enema. Remember the slide, guys? Barium enema, I'm going to grab my mouse right here. And this is the enema actually right there. There's a rectal tube. You insert it in the patient's rectum and you give the contrast. Usually you ask the patient to hold as much as possible. You need the patient to hold the contrast inside, the rectum for more than 15 minutes. And you want to allow that contrast to go all the way up the intestine and down the small intestine. And what you're looking for fecaloma or obstruction of the intestine. All right, and then they perform x-rays and try to see where the obstruction is. Now I'm going to talk about T drains. So T-tube drains are drains that they put in the between the common bile duct and the hepatic duct to drain bile. All right, sometimes there are stones and sometimes there's stenosis. So they put the T-tube. So I just want you guys to know what a T-tube is and have like an image to recall it whenever this presents itself. Now we're going to talk about chest tubes. Chest drainage. This is a very common question on the NCLEX test. Chest tube troubleshooting. You need to know that. Bubbling in the chest tube. You're going to ask yourself, is it in the water seal? If yes, you gotta ask yourself, is this intermittent bubbling? If yes, that's normal. If no, it's continuous bubbling, then find the leak and tape it. There is a leak somewhere. And then you gotta ask yourself, is it in the suction control chamber? If yes, then you ask yourself, is it intermittent bubbling or continuous bubbling? If it's intermittent bubbling, then increase the suction volume. The patient, there's not enough suction pressure, so you increase the suction pressure. If it's continuous bubbling, then that's normal. All right. Labor and delivery complications. I'm not sure. Yeah. Let's talk about those. So signs of uterine tetany or uterine hyperstimulation of the uterus, right? Uterus. So first off, if you've got signs of hyperstimulation of the uterus, you need to stop Pitocin if it's there. And then contractions should not be longer than 90 minutes or less than 2 minutes apart. So that we're gonna memorize this forever. How do you time contractions? We already talked about this. The frequency and the duration and intensity is subjective, right? Let's see, complications. We're gonna talk about a painful back labor. So if the patient, her water didn't break and the patient is still walking, so you put, the patient will put the face down and scoot their butt up, while standing, lean forward, and then you can fist massage the lower back. If lower back pain while the membrane was, what did I do? While the membrane is, how do you say it? Membrane is ruptured, then the patient is going to be in complete bed rest. Then if there's lower back pain, you reposition the patient and you pull the knees to the chest and you put the head forward. So another complication could be prolapsed cord. So if the cord is presenting, and this is during the second stage of labor, during delivery, if the head came out of the pelvis and then you're checking for the cord and it's around the neck, then you push the head back inside and you try to release the cord. So that's it. And then you ask the patient to be in a knee chest position. So interventions for all other complications, you're gonna use Lion or Lion. Left side, increase IV fluids, give oxygen, and notify provider. If patient is getting Pitocin, then stop Pitocin first and then do Lion. Fetal monitoring patterns. Low fetal heart rate, less than 110, you're gonna perform Lion. If the patient is on Pitocin, you're gonna stop it. So now we're gonna talk about the LV rule. Any position that starts with, or any abnormality that starts with L or V, you're gonna use Lion. So L, Lion. Starts with L, you use Lion. So let's say high fetal heart rate, over 160. What do you use? Do you use Lion? No, you don't. Why? Because it starts with H. It doesn't start with L. It doesn't start with V, right? So L's and V's are dangerous positions. So Any positions that start with L, you perform Leon. If you see the word variable, then you put the patient in a push position. Let's practice. So low baseline variability. It starts with L, Leon. High baseline variability, you don't do anything. Late deceleration, Leon. Early deceleration, you don't do anything. Variable deceleration, push position. See, it's that easy. So we're going to talk about some OBGYN medication that you need to get yourself familiar with. You need to memorize those actually. So we're going to talk about tocolytics, stops labor. These are medication that stops labor. This is the opposite to the Pitocin, all right? Tocolytics, they stop labor. Terbutaline causes maternal tachycardia. That's a side effect for terbutaline. So terbutaline, it stops labor, but it causes the mother tachycardia. Magnesium sulfate, it also stops labor, but it causes hypermagnesemia. So they decrease contractions, they decrease heart rate, they decrease blood pressure, they decrease reflexes, they decrease respiratory rate and level of consciousness. So you need to watch for these side effects. So your goal is to keep the respiratory rate above 12 and the reflexes at +2. So if they go +1, then that's a no-no, okay? You give Pitocin, you counteract that. So oxytocins, another family of medication you need to know about, which is it stimulates and strengthens labor, like Pitocin. They causes uterine hyperstimulation. Contractions, again, this is a very important rule. Contractions more than 90 minutes or contractions back to back less than 2 minutes apart, then you need to stop Pitocin right away. This is abnormal, right? Another medication that performs the same function as Pitocin is methargine. It causes high blood pressure as well. That's a side effect of it. Alrighty, so fetal lung maturity medication. There are two of them. Betamethasone, it's given to the mother IM before the baby is born, and then the betamethasone is transmitted to the baby through the umbilical cord. You also got the Surventa. You've got the Surventa, which is the surfactant, if you heard about it. It's transtracheal. You give it through the trachea of the baby when the baby is born. And do not administer pain med to a woman if the baby is likely to be born. So if the baby is 13 minutes away, you suspect that the baby is going to be born in 30 minutes, then you stop giving IV medication. Just small slide about gestational diabetes during pregnancy. I would like you to read the slide, print it out, make sure you know it. These patients will have high blood glucose, and they definitely bring extra glucose to the baby, and the baby will gain weight. Okay, alrighty. And this slide is funny, so make sure you do not pass the bucket. If you're gonna choose, like, call your provider or call, the whoever, like the NP or the doctor, or make sure that you've done everything you can before you pass the bucket. This slide, we discussed it in earlier webinars, the body mass index. I just want you to memorize the normal range. It is 19 to 25. Anything below 19 is underweight, above 25, that's overweight. Now we're going to talk about drug levels a little bit. No, actually, we discussed this slide. Let's move over it, okay? You guys know this. Let's talk about vesicular lung sounds. What are vesicular lung sounds? Vesicular lung sounds are normal lung sounds that you can hear them over the thorax. They are low pitched and softer than bronchial breathing. And I'm going to show you a slide. All the B's on the slide, these are bronchial. These are high pitched sounds, but the V's are the vesicular lung sounds, which are low pitched and softer sounds. Okay, and this is the posterior slide. Cushing syndrome, it's very, very important. Cushing syndrome, just memorize it. Cushing syndrome is hypersecretion of adrenal cortex, over secretion of cortisol. Okay, so you've got the adrenal glands, that's the adrenal cortex, it secretes cortisol. Signs and symptoms. So Cushing syndrome and side effects of cortisone, they are the same. Okay, so Cushing syndrome equals side effects of steroids. You memorize one of them as if you memorized both. So signs and symptoms of Cushing syndrome as same as steroid side effects. We've got this picture right there. We call this man right here Mr. Alpha Slice. So What I like to focus on, like you need to memorize all of them, but you know, like gynecomastia, moon face, red cheeks, personality changes, hyperglycemia, fluid retention, small extremities, thin extremities, fractures, osteoporosis, bruises and petechia, amenorrhea, hirsutism, that buffalo hump on the back if they stand sideways. These are very important side effects. Just keep them in mind. All right, let's talk about diabetes mellitus. I know you guys love it. When you get a diabetes mellitus question on the NCLEX, I want you to smile because you know this. We've solved so many questions about diabetes mellitus. So a brief definition, which you already know, is low production or response to insulin, which leads to abnormal metabolism of carbohydrates and elevated level of glucose in the blood and urine. So diabetes mellitus, you've got two types, type 1 and type 2. Type 1 is the insulin dependent. So it is a deadly disease. Treatment, it's simple. It's insulin, most important, then exercise, and then diet. Don't sweat over the diet. There are 4 types of insulin that are required of you to know for, you know, the boards of nursing. You've got insulin R, you've got insulin N, you've got, which is the NPH, you've got Humalog, you've got Lantus, all right? And we're gonna move to this beautiful table right here, which I wish that you guys will print out and hang it on your study wall. So we're gonna start with onset, peak, duration, and then some pro tips. And we're gonna talk about the 4 types of insulins that we have. All right, so insulin R, the onset, it's rapid onset. So within 1 hour, it will start working. It peaks after 2 hours and duration is 4 hours. Pro tips, it's the only IV drug of choice, like IV insulin of choice when we are talking about IV insulin, especially in cases of DKA and the other form of hyperglycemia with type 2 diabetes. We're going to talk about it in a minute. So insulin N, it's an intermediate acting insulin. It starts working within 6 hours. It peaks after 8 to 10 hours actually. A duration, it stays in your body for 12 hours. Tips, never IV, never, never, never. Okay, Humalog, or they also call it Lispiro. It's fast acting within 15 minutes. It peaks after 30 minutes, stays in the body for 2 to 3 hours. You give it only with meals. You're standing at a bedside and you give it to the patient once they start eating. You've got the Lantus onset. It's a long onset. Peak never peaks. Duration 12 to 24 hours. Most probably patients will take it at 9 p.m., but I've seen physicians who order it BID 9 a.m. and 9 p.m. Tips, no risk for hypoglycemia because the insulin will be at the same level all the time. So never pick the answer that says AC or before meals. This means 13 minutes before meals. And when we're talking about Humalog, that you see the red star over there. So insulin storage, don't sweat over it. If the patient is at home, just tell them to put everything in the fridge. But if you are in the hospital, then if you did not open the vial, put the insulin in the fridge. If you opened it, you put it outside of the fridge in the patient medication drawer, and you put a label on it with an expiry date of 30 days. Okay, you give patient education, you know, for home storage, just say refrigerate, whatever. More exercise will result in less insulin demand and vice versa, which is true. Insulin always depends on the acute check. So if a patient is sick, never ever say, I'm not gonna give him insulin because he's not eating and he's sick. No, you do the acute check, and according to the sliding scale, you give him insulin. Complications of type 1 diabetes mellitus. So hypoglycemia, insulin shock, right? Either you gave the patient too much insulin, or he took too much insulin, or he took insulin but not enough food, or he's doing too much exercise. That will result in brain damage. Hypoglycemia causes cardiac arrest. This is a very serious situation. Signs and symptoms of hypoglycemia: you've got the nervous system collapse, they call it, slurred speech, slow reaction, confusion. And then you've got weak pulse, hypotension, palpitation, cold, clammy skin. Let's talk about type 2 diabetes, which is the oral medication. That is an adult onset. You do not have a pediatric patient who has type 2 diabetes, never. So treatment, you start with diet. It's the most important thing. You tell a patient to eat 5 to 6 times a day. Exercise is the second most important, and then medication at last. So don't sweat a lot after medication if a patient missed a pill in the morning. So oral medication, I want you to memorize those medication, those families, 5 of them, and you need to memorize them. And metformin and pioglitazone, they have interactions with Lasix, and pregnant women, they are contraindicated. So make sure you familiarize yourself with those. And you know, it's very important because a lot of nurses get mixed up between oral anti-glycemic medication and antipsychotic medication. Treatment of hypoglycemia, there are 2 kinds. If the patient is conscious or unconscious. So if conscious, you give him fast metabolized carbohydrate like sugar, chocolate, orange juice, 3 tablespoons of sugar with a cup of water. If you want to give, if the question is asking you like if they have 2 options, they're asking you to choose 2 options, then you're gonna choose 2 food categories. So or 2 food macronutrients. You're gonna choose sugar and starch, or sugar and complex carbohydrate, or sugar and protein. Okay. So never choose 2 sugars. Never pick up that answer. So if the patient is unconscious, what you're gonna do? If the patient is at home, every single patient have IM glucagon in the fridge. So you just ask the family member to go grab that one and give it to the patient IM. If the patient is in the hospital, that's easy. You give IV dextrose, usually D10 or D50. DKA, it is hyperglycemia of type 1 diabetes. Major causes, viral infection. 2 weeks after viral infection, the patient is at a very, very high risk for DKA. So you ask the family if they had like influenza, parainfluenza, rhinovirus, coronavirus, anything that can trigger DKA. Usually patients with type 1 diabetes, if the ACU check reaches 300, those patients will be knocked out. They will go unconscious. So usually the cause of hyperglycemia is uncontrolled food consumptions. They eat a lot, or not enough insulin. So they are eating, but they're not taking enough insulin. So DKA, D, we're going to talk about dehydration. K, ketones in urine. Ketones, they show up after the fat is burned. Kussmaul breathing, we talked about this. The ABG is going to result as metabolic acidosis. Those patients will have hyperkalemia, which is the 3rd K. And then the A's, you've got acidosis, you've got acetone breath or fruit breath, and you've got anorexia, usually due to nausea and vomiting. Treatment, D5% with insulin. We say insulin is the doorkeeper or the key to the cell to bring the potassium inside the cell, and then hydration, of course. These are not fatal, and patients will survive. So the other form of hyperglycemia is the hyperglycemia hyperosmolar non-ketotic syndrome. So these patients will not have ketone in urine. So it's called HHNK, and this is with type 2 diabetes. And major causes are acute pancreatitis, sepsis, myocardial infarction, dehydration, uncontrolled food consumption. But those patients, if they can be walking around with an ACU check of 500 or 550, but as soon as they cross the 600, those patients will get unconscious. Treatment is very easy, it's IV hydration, but those patients, they have a higher fatal or lethal, or have lower prognosis than the type 1 diabetes. Complications of diabetes mellitus: peripheral neuropathy, like blindness, impotence, loss of bladder control, poor tissue perfusion, renal insufficiency, foot ulcers, delayed wound healing, and impotence. We actually wrote impotence twice. Usually HbA1c normal level is 4 to 7. Do not ever say I didn't teach you that. Normal level for HbA1c is 4 to 7. So if a question came during the test and they said HbA1c is 4, what do? You skip insulin, you increase insulin, you eat more. No, you don't do anything, because that's normal. So patients higher than 8, that's bad. HbA1c is an indicator for long-term glucose control. Usually you test HbA1c every 3 months. Some definitions, we're getting back to pregnancy, some definitions and facts about pregnancy. These are, they are important, but you're not gonna see them on the first 75 questions, but they are important. You need to study those. You need to know them. So let's start with ballottement. This is a sharp upward pushing against the uterine wall with a finger insertion into the vagina for diagnosing pregnancy by feeling the return impact of the displayed fetus. So basically, back in the old days when they wanted to examine if this woman is pregnant or not, they will feel the baby. Fundus is the top of the uterus. You need to know that. Due date. How do you calculate the due date? First day of the last menstrual period, you add 7 days and you subtract 3 months, and then you've got your due date. Average weight gain. Usually during the whole pregnancy, the woman should gain 28 pounds, plus or minus 2 pounds. How do you calculate that? So gestational age. How old is her pregnancy? 8 weeks, 10 weeks, 20 weeks, whatever that is, you subtract it by 9. So for example, if the woman is 32 weeks pregnant, you subtract by 9, then she should gain an average weight of 23 lbs. So during the first trimester, which is from 1 to 12 weeks, the woman should gain 1 pound per month. So a total of three pounds, right? Because it's 12 weeks, 3 months. So that's first trimester. The fundus is not palpable during the first trimester, and during the first trimester, the mother is always a priority in the question. So if there is a problem with the mother and the fetus, who do you rescue first? You rescue the mother. If you can palpate the fundus with a patient, or the patient gained more than 10 pounds, then that pregnancy is not real. Either there's a hedated formal or like an ectopic pregnancy, or the patient is not in her first trimester. So if you can palpate the fundus, then there's something wrong. All right. So a hedated form mole is a non-cancerous tumor that develops in the uterus as a result of non-viable pregnancy. Right. Second trimester actually is from 13 to 27 weeks. The mother will gain 1 pound per week. The fundus is at the umbilicus or just barely below it. The mother is still a priority in this stage, and you always prioritize mothers in those type of questions. The fundus is usually at the level of the umbilicus by week 20 to 22. With third trimester, that's from week 28 to 40. The mother will still be gaining 1 pound per week. The fundus is way above the umbilicus. The baby is the priority here. So if there's a problem, you just go to C-section right away, and patients will survive. So signs of pregnancy, and this is nice to know. It's not a urine pregnancy test, and it's not a blood pregnancy test. So it's either fetal x-ray. These are confirmed signs of pregnancy. Fetal x-ray, you did an x-ray and you saw a skeleton in that pelvis, okay? So fetal present on ultrasound, auscultation of fetal heart rate, or that old school examining of a pregnant woman, which is palpating the baby. Blood and urine test is a maybe sign of pregnancy. So if you get it on your NCLEX question, you do not choose it as a confirmed sign of pregnancy. There are some signs that a patient is pregnant, which is discoloration of her genital area and the vagina and the labia. We're going to talk about them real quick. So you've got the Shedwick, the Goodall, and the Higger. So the Shedwick sign is a bluish discoloration of the cervix, vagina, and labia resulting from increased blood flow. It can be observed as early as 6 to 8 weeks after conception, and its presence is an early sign of pregnancy. Goodall sign is an indication of pregnancy. It is a significant softening of the vaginal portion of the cervix from increased vascularization. This sign occurs at approximately 4 weeks gestation. On the other hand, Hogger's sign is a non-sensitive indication of pregnancy in women. Its absence does not include or does not exclude pregnancy. It is demonstrated as a softening of the consistency of the uterus and the cervix seem to be two separate regions. So office visits and hemoglobin levels for pregnant women. Doctors they usually visit once a month until week 28. Then every 2 weeks by the week 36, they do weekly visits until delivery. Hemoglobin, usually the normal is from 12 to 16, but in pregnant women, first trimester, a hemoglobin level of 11 is normal. Second trimester, 10.5 is normal. Third trimester, 10 is normal. So some discomforts during pregnancy, morning sickness, how do you deal with it? During the first trimester, you give dry carbohydrates. You always choose toast and or crackers, and you give them to the mother before she leaves the bed. Urinary incontinence, especially during the first and third trimester. So usually patients void every 2 hours. And you're gonna ask why, like the first and the third. The reason is in the first trimester, the uterus will be inside the pelvis. It will pressure on the bladder. And on the third trimester, the uterus is huge and it will pressure on the bladder. Second trimester, it's just floating in the abdomen and it's not causing any problem. Again, another discomfort with pregnancy is difficulty breathing or dyspnea, especially during the second and third trimester. Usually mothers, they sit in tripod position or orthopedic positions, both hands on both knees, they lean a little bit forward, they try to breathe heavily. Back pain during second and third trimester, they do pelvic exercise. I have a picture that show you the pelvic exercises, but they also put their foot on a stool if they're at work or desk job or whatever. So some medical terminology that I would like you guys to know. This is not related to pregnancy. This is related to spinal injury. Autonomic dysreflexia. Okay, AD, autonomic dysreflexia, is a condition in which your involuntary nervous system overacts to external and bodily stimuli. It's also known as autonomic hyperreflexia. This reaction causes a dangerous spike in blood pressure. So the patient is in severe pain, severe blood pressure. The blood pressure during autonomic dysreflexia is above 200, and it might cause the patient, intracranial hemorrhage. Usually these patients have spinal injuries and they cannot move. So a noxious stimuli is an actually or potentially tissue damaging event. Okay, so sometimes you got bladder retention. Like patient has spinal injury, he's paraplegic, he has urinary retention, and the bladder is pushing on the spine, for instance, and it's causing tissue damage. So quick review of the slide: diabetes insipidus versus SIADH. They are completely the opposite. The only thing in common is that they both experience excessive thirst. But if you look at them, diabetes insipidus, high urinary output, SIADH is the opposite, low levels of ADH and DI. SIADH have high ADH and so forth. So make sure you print the slide out and you memorize it. This slide is just to show you the difference between incentive spirometer and aerosol chamber. There's a lot of difference. Incentive spirometer is used for breathing exercises, while aerosol chamber is used for medication administration. Like those inhalers and puffs. So you need to make sure that you know the difference. Now we're going to talk a little bit about psychology, psychotics versus non-psychotics. So the vast majority of patients on the units are going to be non-psychotic patients, right? So they are reality-based. They might have anxiety, mood issues, depression, but non-psychotic patients have insight about their sickness and know what their problem is. They are reality-based and they want to change their problem, right? How do you answer non-psychotic patients? Always use therapeutic communication skills. And you're gonna ask me, give me an example. Examples are, you tell the patient, tell me more. Can you explain what you mean? I see you're afraid. Can you tell me more? How does it feel? Therapeutic communication. Now we're gonna talk about psychotic patients. They are non-reality based. They lack insight. They live in a different reality. Some of the symptoms that they have delusions, hallucinations, and illusions. And we're going to talk about every single one of those. So delusions are actually false fixed belief, or false fixed idea or thought. It's a non-sensory component. So it is not something that patients can feel, touch, hear, or see or smell. It is something they believe. It is a fixed a fixed belief, meaning it does not change. And we're going to give examples, right? There are 6 kinds of delusion, not 6 kids, but 6 kinds of delusions. You've got paranoid, you've got grandiose, you've got somatic, you've got orthomanic, you've got jealous, you've got persecutory. Okay, 6 types. So types of delusions, we're going to define every single one of them. Paranoid delusions is false fixed belief that mafia are trying to harm you. Grandiose delusions is false fixed belief that you are superior, you are the key to the universe, you are Jesus. Like people might say, my hand, if I raise my hand, people will die, stuff like that. So it's grandiose delusions. Somatic delusions, it's a false belief about a body part. They might say, I can melt steel with my eyes, like I have laser beams with my eye. I am a male, but I'm pregnant, stuff like that. So erotomanic delusions is a false fixed belief that another person, usually someone famous, is in love with them. Jealous delusions is a false fixed belief that their partner is unfaithful. And persecutory delusions is a false fixed belief of someone close to them is being mistreated, or that someone is spying on them and planning to harm them. Again, I know you guys are tired, just bear with me. We're gonna finish those slides, and by the end of this webinar, I'm gonna show you something special. All right, hallucinations. Hallucinations are false fixed sensory experiences. So they involve hearing, they involve all 5 senses. So hearing, smelling, tasting, seeing, and touching things. Auditory hallucinations, they hear voices, self-destructive commands. So those voices are asking the patient to harm self. Visual hallucinations, that's obvious. Tactile hallucinations, feels something is touching you, touching your body. You feel ants on your shoulder or whatever. Gustatory hallucinations, which is tasting. This is a very rare on your NCLEX test. Olfactory hallucinations, which is smelling. Again, this is very rare on your NCLEX test. So example, I believe I have worms in my poop versus I feel I have worms on my poop. So the first one is delusion because it's a belief. The second one is a hallucination because it has feeling to it. I feel. So see the difference between delusions and hallucinations. Now we're going to talk about illusions. Illusions, same as hallucinations. They are false fixed sensory experiences, same as hallucinations, but they are misinterpreting reality. So you're going to look for a referent in the question. What are they referring to? Example, look, I see a bomb. You should look in the question to see if there's anything that refers to an object in the reality, like a fire alarm, and the patient thinks that the fire alarm is a bomb. Another example is a patient looks at the doctor and think he is a demon, right? There is a referent. So I just want to touch base on dementia. Dementia is irreversible, right? The goal is to maintain it and prevent it from getting worse. Delirium, we're going to talk about it. Dementia is a chronic feature. So it starts somewhere and it advances steadily over time. But delirium, it's an acute episode. So delirium is an acutely disturbed state of the mind that occurs in fever, intoxication, and other disorders, and is characterized by restlessness, illusions, and incoherence of thoughts and speech. So psychotics, they are 3 types actually. You've got functional psychosis, you've got psychotic dementia, and psychotic delirium. We're going to explain those. So functional psychosis, patients with functional psychosis can have jobs, relationships, vacations, etc., as long as they are taking their medication. Examples of functional psychosis, and I hope you guys memorize those diseases. Like memorize that functional psychosis include those diseases like schizophrenia, schizoaffective disorder, major depression, and state of mania disorder. So how to answer questions like that? So they have the potential to learn reality, right, through 3-step process. So you give them their medication, definitely, and then you teach them the reality. That's why they are functional, because you can teach them reality. So acknowledge feelings, point out to reality, and then set limits, and then reinforce limits if they're still acting weird. Psychotic dementia, actually, it causes brain damage and will only get worse. So we said dementia. Examples of patients with psychotic dementia are Alzheimer, organic brain syndrome, senility, which is like dementia, closed head injuries, Waring-Korsakoff syndrome. So Waring-Korsakoff syndrome, actually alcoholism causes delirium, but chronic alcoholism will switch to psychotic dementia. How to answer those type of questions? Dementia is irreversible. We already discussed that, but there's a two-step process to deal with those kind of patients, and you really need to sympathize with those patients. So acknowledge feelings and then redirect thoughts. I'm gonna give an example. If a question says, an Alzheimer patient is in the hallway saying, they are coming, they will kill everyone. How are you gonna deal with this patient, right? How are you gonna deal with this patient? So you're gonna acknowledge feeling, tell him, yes, I know that you're afraid, but then you're gonna move him to his room and say, let's go to your room. Your room can be safer than sitting in the hallway. Psychotic delirium, FYI, if if the chemical insult is prolonged, then delirium will develop into dementia, and that's the alcoholic, chronic alcoholism state or example. So psychotic delirium is a temporary, sudden onset of loss of reality due to a chemical imbalance. Example of patients with psychotic delirium: urinary tract infection, any sort of infection, fever, withdrawal, any withdrawal symptoms, hypoglycemia, high ammonia, thyroid storm, ICU psychosis, and third day post-surgery. That's very important. If an NCLEX question comes and they say they're talking about psychosis and day 3 after surgery, you need to have that in mind. How to answer those questions: 3-step process. Of course, acknowledge feelings first, reassure the patient that they are safe and this is temporary, and then assure their safety, or vice versa. So terminology that I would like you to learn are flight of ideas is loosening of association. The patients say phrase after phrase after phrase, but those phrases are not linked to each other. All right, so every phrase is talking about something else. Word salad is combining words, so those words do not fit in one sentence. So which is worse, word salad or flight of ideas? Yes, word of salad, because like flight of ideas, you would understand sentences, but word salad, you won't understand anything. Neologos is making new words. So basically, whatever you want to make up, but making up words. Ideas of reference, patients think people are talking about them actually. So ideas of reference. Number one rule to answer psychotic questions is find out what you're dealing with. Is it delirium, dementia, or functional psychosis? When you know what you're dealing with, then you know what step process you're going to use. 2-step process, 3-step process, or whatever the case might be. So be aware of tricky questions. Narrowed self-concept is when a psychotic patient refuses to change their clothes, get out of bed, take a shower, or leave their room. So if he's a psychotic patient, you already know that he's a psychotic patient, then let it be, okay? Give the patient his time, don't stress it. Don't force the patient to go to the bathroom and have a shower. But if you have a non-psychotic patient, but he's depressed, and he's refusing to change clothes, get out of bed, take a shower, or leave the room, what do you do? If he's not psychotic, non-psychotic, then he is reality-based. He knows what's going on. Then those type of patients, you force them, and you basically stay in the room. You say, I'm not leaving the room before you get out of bed, go to the shower, and wash your face. So delegation to LPN, we already discussed those. I'm gonna move over them. And crutches, a lot of crutches, right? 2-point gait. Move a crutch and the opposite foot together. Okay, it's like marching. Move a crutch and the opposite foot together. All right, 3-point gait. You're moving 2 crutches and the affected leg first, and then you follow with the good leg. That's how you do it. 4-point gait is you're taking 1 point at a time. So if you take one crutch, you move the opposite leg, and then you take the opposite crutch and you move the opposite leg. This is how you do it. Okay. So basically, 2-point gates and 3-point gates is for bilateral leg injuries, or bilateral legs are affected, and we're going to talk about that. Brace extremities, so extremities that have brace on them, you just swing through. It's a 3-point gate. Non-weight bearing, you do not put weight on. Brace or a cast or an amputated limb. But if you have a what do you call it? If you have a prosthesis, then you swing through 3-point gate, but you can bear weight on your prosthesis. So even for even, odd for odd. So 2-point gates, or 2-point. So even two affected extremities, you use 2-point gate or 4-point gate. Odd, which is one affected extremity, you use 3-point gate. So how do you differentiate when do you use 2-point gate and 4-point gate if both legs are affected? Yes, if the injury is minor, then you use 2-point gate. If the injury is major, you use 4-point gate. Okay, so mild problems, severe problems. 3-point gate with one affected leg. Stairs, up with the good, down with the bad. Memorize that. So walking with a cane, you always put the cane on the strong side, and you advance the cane with the weak, and you follow with the strong leg. Walker, you pick up the walker, move it forward, put it down, and then walk towards it. That's how you do it. This is a wound vac. They call it a wound vacuum. You apply it to infected wounds, and it helps with healing. And this is another real picture of it. Esophagogastric tube. They also call it the black. What do you call it? The black. I forgot, but I have a slide later. But basically, you put this tube in case of esophageal varices or gastric bleeding. So if a patient is bleeding from esophagus or stomach, you apply this tube and you inflate the balloons, which will apply pressure on the bleeding site. Okay, I told you guys there's a slide about pelvic strengthening exercises, and that's how you do it, especially with patients who have incontinence. Patients who have incontinence, then you encourage them to use pelvic exercises. Okay, so sickle cell anemia patients, you've got RBCs, usually most common among African Americans, and this is the slide. Just memorize it. Thyroid, the thyroid gland, primary function in the body is to regulate your metabolism, right? So this is the anatomy of the thyroid gland, and this is the parathyroid gland. Hyperthyroidism, which is Graves' disease, the most common form of hyperthyroidism. Treatment, you've got radioactive iodine. Usually, the patient will stay radioactive for 1 week, and you use PTU and thyroidectomy. Total thyroidectomy, you will need lifelong hormonal replacement. Very hard to save the parathyroid actually on total thyroidectomy. So subtotal thyroidectomy, you do not need lifelong hormone treatment, but you have to pay attention for something called thyroid storm. What is a thyroid storm? It's overacting of the thyroid gland. Signs and symptoms are fever more than 104 or 40 degrees, hypertension and tachycardia more than 200, psychotic delirium, and treatment is to keep temperature down and give oxygen high flow at 8 to 10 liters. Usually, 2 nurses take care of one of those patients, and your main job is to keep that patient febrile. So thyroid storm is overacting of the thyroid gland. Post-op risk, for the first 12 hours, it's airway and hemorrhage. After 12 hours, it is so it's tetany and the thyroid storm. So hypothyroidism, signs and symptoms, you've got obesity, down personality, heat tolerance, cold intolerance, hypotension, bradycardia, myxedema. Myxedema coma, actually, it's all of these signs and symptoms. Treatment is to give thyroid hormones, right? Hypothyroidism, you give thyroid hormones, levothyroxine. Risk for myxedema coma if the patient went to sedation. right? And that's a lethal side effect. Um, so so always call provider before holding the levothyroxine. So this is very important. You don't want the patient to go into um, major side effects. So if you're gonna hold a thyroid hormone, you call the physician and let them know, especially before operation. Signs of hypoparathyroidism, okay, Schwastek signs and Trousseau signs. We're going to talk about them. They are hypocalcemia. So any patient with hypocalcemia, you will see those signs. The Schwastek sign is a clinical sign of existing nerve hyperexcitability, which they call it tetany, seen in hypocalcemia. It refers to an abnormal reaction of the stimulation of the facial nerve, just like that. And then you've got the Trousseau signs, which is hyper extension or hyper extension, hyper extension, hyperflexion of the carpal muscles in the arm when you apply a blood pressure cuff. Sweat test, actually, with cystic fibrosis, this is the test of choice to diagnose cystic fibrosis, and you test the chloride in the patient's sweat, and this is the machine where you test it. Flail chest, you see those bones, it's those type of fractures, they call them flail chest, usually with chest trauma, and you need to pay attention for those patients for shortness of breath, pneumothorax, and hemothorax. Congenital heart defects, we've talked about those trouble and non-trouble, and so a patient in trouble means that he will need surgery, everything is bad, short life expectancy, delayed growth and development, exercise intolerance. A patient in trouble, in no trouble, no need for surgery, okay? So he has a congenital defect, but he's in no trouble. He doesn't need surgery. General rules, right to left is trouble because the R comes before the L in the word trouble. So R in the word trouble comes before the L, that means the patient is, so right to left chant is trouble. So right to left chant means that patient is cyanotic. Any defect starts with D is trouble, and we're gonna give examples. Or have all heart defects have murmur in them. So murmur is not an indication for trouble or no trouble. And before discharging any patient with congenital disorder, you do an echocardiography. The etiology of Fallot, it has 4 characteristics. It's very important to memorize those. There are only 4 characteristics: ventricular defect, pulmonary stenosis, overriding aorta, and right hypertrophy. Just memorize them. And defect that starts with T is trouble. So let's see. Let's give examples. So VSD, ASD, ventricular septal defect, or atrial septal defect is no trouble. The etiology of Fallot, it starts with T, it's trouble. Truncus arteriosus start with T, is trouble, so forth. You guys know that. Infectious disease transmission precaution. Do I need to go over these? Contact, fecal or oral transmission, right? The diseases are C. diff, hepatitis A, herpes, staphylococcus infection, respiratory syncytial virus. So you put those patients in private rooms, contact precaution, and you can cohort patient of the same disease. PPEs that you're going to use gown, gloves, and you're going to use dedicated supplies. All right, droplet, coughing and sneezing. Those droplets will travel 3 feet. Diseases are meningitis, hemophilus influenza, which can cause epiglottitis, right? We talked about epiglottitis. It's a very serious situation. Whenever you hear muffling sounds, a patient is drooling, stridor, then the patient is in epiglottitis, and he is at risk for laryngeal edema and compromised airway. You need to pay attention. Private rooms, cohort patients as well. PPEs that you're going to use gloves, mask, and dedicated supplies. You only use gowns if you are doing patient contact. Airborne, the airborne floats in the air, so you need to put those patients in negative rooms. Examples: measles, mumps, rubella, tuberculosis, and varicella. Negative pressure rooms, you can cohort patients with the same disease. PPEs, gloves, mask, N95 mask if a patient has TB, dedicated supplies, and you only use gown if you're doing direct patient contact. How do you don and drop your PPEs? So gown, mask, goggle, we memorize this. It's gown, mask, goggles, and gloves. And how do you drop them? Alphabetic order, which is gloves, goggles, gown, and mask, right? Trochanter roll. and this is very common on medical surgical units with orthopedic surgeries, total hip replacements. You put this trochanter roll under the patient at the level of the trochanter until just above the knee, which will keep the patient in that position, neutral position, to prevent dislocation of the hip. So peritoneal dialysis, I want you to really know this slide. You give the diacylate into the peritoneum, you keep it there for like 3 to 4 hours, and then you drain it, and then you do the cycle all over again. How do you test for diaphragmatic excrusion? You ask the patient to inhale, and then you use percussion to see if your percussion is dull or not, and then you would know the distance that the diaphragm is traveling during inhalation and exhalation. How do you test for lung expansion? You do palpation. Through palpation, you test for lung expansion. Vesicular breath sounds, we already discussed those. And ribs and intercostal spaces, you know those. You need to have like an anatomy awareness. Kaposi sarcoma, you see this kind of sarcoma with HIV patients. It's very common. So Kaposi sarcoma is caused by infection with a virus called Kaposi sarcoma associated herpes virus. So it's also known as human herpes virus 8. It is the same family of Epstein-Barr virus. Facts to keep in mind about HIV: oral and esophageal infections like Candida, they will get this a lot because of their immunosuppression. Risk for Kaposi sarcoma and skin and lymphoma. This is a skin cancer that is treated with chemotherapy. Pancytopenia, everything is low. RBCs, YBCs, platelets, everything is low. So protective reverse isolation if the patient is neutropenic. Blood stains, if you have blood stains on the floor, then you need to clean them with bleach and water. Concentration is 1 to 10. Bleeding precaution, no IMs for this patient population. No rectal temperature if platelets are low. So punch biopsy is actually a skin biopsy. I want you guys to familiarize yourself with it. Any skin disorder, usually dermatology doctors, when they come to the unit, they have this pen actually in their pocket at all times, and they do perform skin biopsy. After they remove the skin, they usually do a stitch after that. Pre-eclampsia signs and symptoms, very important. You need to familiarize yourself with them. Elevated blood pressure, weight gain, water retention, elevated protein in urine, headaches, nausea, vomiting, pain in the abdomen, changes in vision. So proteinuria in the urine as well. Hyperreflexia, which if they have more than +2 hyperreflexia, then the patient is having signs of preeclampsia. And also hyperreflexia is a sign of hypermagnesemia as well. Reflexes, this is the grading of them. 2 is the normal, +2 is the normal. Above 2 are the hyperreflexes, below 2 are hyporeflexes. Portable bedside radioactive iodine protective shield. I just want you guys to familiarize yourself with it. You use this with patients who have implantable seats for radiation therapy. Open angle glaucoma, we discussed this in the past. I just want to remind you, normal intraocular pressure is from 10 to 21 millimeter Hg. Symptoms of glaucoma are cloudy, blurry vision, or loss of vision. Artificial lights appear to have rainbow or halo around them. Decreased peripheral vision, of course, pain like headaches, nausea and vomiting, and this is the tonometer that you measure your intraocular pressure. As I said, like Kegel exercises or pelvic exercises, you use them with patients who have urinary incontinence. So male patients who did TURP of the prostate, then you ask them to do pelvic exercises. This dyspareunia is painful sexual intercourse. So this is just a definition. Pelvic exercises. What is that? Functional incontinence is a form of urinary incontinence in which the person is usually aware that he needs to urinate, but for one reason or another, it could be physical or mental, they are unable to get to the bathroom. The loss of urine can vary from small leaks to full emptying of the bladder. That's why they provide them with adaptive clothing. Systematic lupus erythematosus, a couple of definitions. Patients should avoid direct exposure to sun and to any other type of ultraviolet light, including tan beds and certain kinds of fluorescent lights. Patients who are immunosuppressed should wear gloves if they are working outside in a garden, and they need to wear long sleeves because they are at risk for injury, and simple cuts can be transformed into huge infections. So those type of patients, they have joint problems, and it's very hard for them to like sit down on the floor and work in a garden and stuff like that. Some of the signs and symptoms of systematic lupus erythematosus are highlighted in this picture. I want you to know that butterfly rash is a hallmark sign of systematic lupus erythematosus. So we're going to talk a little bit about ECG real quick. Big box, 0.2 seconds, small box, 0.4 seconds. This is a 6-second strip. This is a 1 beat, which starts with P, QRS, T, and U wave. The P is the atrial kick, and QRS is the ventricular pump. So PR interval is 3 small boxes. It ranges from 3 small boxes to 1 big box, and QRS from 1.5 small box to 2.5 small boxes. And the heart rate is usually 60 to 100 beats per minute. So we're going to talk about R to R interval, which is in this picture, and that will allow you to calculate the rate. So the things that I'm looking for to read an ECG are rate to rhythm, P wave, and QRS. Okay, so this is a normal sinus rhythm, and you can see that every beat, so every R to R are equal, and every beat has a P, QRS, and a T wave. So if you count the R's, 1, 2, 3, 4, 5, 6, 7, so that's a heart rate of 70. Rhythm is regular. P wave is present before every QRS, and QRS are narrow. So these are what I'm looking for. So let's see this strip. Rate, rhythm, P wave, QRS, right? Rate is normal. If I look at it, 1, 2, 3, 4, 5, 6, 7, 8, that's 80. Rhythm is regular because R to R are equal. P wave is present before every single one, and QRS is narrow complex. But you're gonna ask me, what is this? This is a PVC, premature ventricular contraction. So this is a normal sinus rhythm. This is also a normal sinus rhythm. If you calculate the R's and you see the P's, the narrow complex and everything. So what is this? First, I'm going to calculate the rate, right? 1, 2, 3, 4, 5 QRS complexes, that's 50. The rate is 50. So I'm going to see the rate, rhythm, P wave, and QRS. So rate, bradycardia, rhythm, regular, P wave, present, QRS, narrow. This is sinus bradycardia, right? This is another form of sinus bradycardia. And let's look at this. What is this? Oh my God, let's count the QRS. It's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 140. That's the heart rate. So heart rate is tachyrhythm regular. P wave is present before every QRS, and QRS is narrow. That's sinus tachycardia. Alrighty, what is this? Whenever you see P-like saw waves, you call it atrial flutter, okay? So narrow complex, saw waves, you call it atrial flutter. If you see irregular R to R with narrow complex, so irregular rhythm with narrow complex, you call it atrial fibrillation, okay? No questions asked. So this, if it's narrow complex and you feel that it is tachycardia, you don't right away call it sinus tachycardia. You count the R's. So how many QRSs here? I think you have like 18 QRSs, which is the heart rate is 180, which means that it's more than 150. So this is an SVT, supraventricular tachycardia. And this is sinus tachycardia. So this is 140 heart rate, and the above rhythm is 180. Okay, anything above 150, call it SVT. Look at this beautiful Mona Lisa right here. So rate, rhythm, P wave, and QRS. This is tachy, definitely. Rhythm is regular. P, you don't see a P wave. QRS, it's wide. You call this ventricular tachycardia. This is another form of ventricular tachycardia, and you can apply the same characteristics to it. This is another form of ventricular tachycardia right here in the middle. Let me show you right here. If you see this, this is another form of ventricular tachycardia. Just memorize those rhythms, print them out, memorize them, okay? So you can apply the same characteristics to them. Let's see, what is this rhythm? Any DNA-like rhythm, you call it torsade de pointe, okay? This very noisy, it doesn't have a unique structure, it's all over the place, that's ventricular fibrillation, right? This is asystole, okay? It doesn't need a genius. Let's talk about some psychotic disorders. Dissociative identity disorder. Dissociative identity disorder, formerly called multi-personality disorders. And there's one movie that I love that, you know, the character of the movie has 24 personalities inside of one person. So each of these personalities have a unique name, unique thinking, feeling, and behaving. This next slide, I'd like you to print it out and read it, highlight it, look at it every day. Just compare, you know, like week 12 to week 36, and you know, different weeks. Just try to memorize it. It's very important. Fluid imbalances, real quick. Signs of overload, volume overload. Dependent edema in the extremities, rapid weight gain, rapid pulse, dyspnea, moist lung sounds on auscultation like crackles. Skin is pale and cool, and patients have headache. Symptoms associated with fluid volume deficit, which is hypovolemia, would include increased thready pulse, decreased blood pressure, postural hypotension, increased rate and depth of respiration, and poor skin turgor. Let's talk a little bit about iron. Iron facts. Any source of iron is best absorbed when you take it with vitamin C, like tomato. tomato. Iron absorption is inhibited if you take it with calcium or coffee. Sometimes you give patients chewable calcium. That's a no-no. Iron-rich food are beef, liver, sardines, lentils, spinach, pumpkins, and enriched cereal. Let's talk a little bit about signs of nerve compression and indication of laminectomy. When do I know that I need to perform laminectomy for this patient? So um, pain, paresthesia, paresia, you perform, basically these are indication for laminectomy. So you need to know, where is the laminectomy? Is it cervical, thoracic, or lumbar? So if the laminectomy is cervical, then you think about diaphragm and upper extremity. You talk about ventilation, movement of the upper extremities, and the feeling of sensation in the upper extremities. Thoracic, you talk about abdominal muscles and gut, and you look for cough and bowel sounds. Lumbar, you think of bladder and legs, and you look for the last time the patient had a urine output. So post-op care for patients with laminectomy, you always emphasize on the log roll, never twist the spine of the patient. So this is the picture. 3 people usually help the patient for positioning of the patient. Do not dangle the patient, which means do not make the patient sit at a bedside and dangle his legs. Usually you limit it for 10 to 15 minutes. Limit sitting on a recliner or a chair for 30 minutes at a time. Patient may walk, stand, lay down without restrictions. Post-op complications, actually you need to know where the laminectomy is performed, and then you can pick up the complications that you're looking for. If a patient did a cervical laminectomy, then pneumonia and atelectasis. If thoracic, then you look for aspiration pneumonia, paralytic ileus, and paralytic ileus is very common after bowel surgeries as well. So lumbar, you look for urinary retention. Laminectomy with fusion, what does fusion mean? So if the fusion was taken from the iliac crest, I'm gonna show you a slide, a picture actually. See that bone graft over there? So they combine those 2 vertebrae with that bone graft, and that will be one huge big vertebra. So they basically removed the disc and did fusion. Discharge teaching for patients with laminectomy, you tell them you do not sit for more than 30 minutes for the first 6 weeks, lay flat and draw log roll for 6 weeks, no driving for 6 weeks, lifting restrictions, do not lift more than 5 pounds, permanent restriction, lift, bending the waist is prohibited. Instead, you squat and lift. Okay, cervical laminectomy, they cannot lift objects above their head, period. No horse riding, no dirt biking, no jerky, amusement park rides, basically no strenuous activity on the spine. Let's see, licorice. Usually patients, they keep this in their pockets to treat heartburns and stuff, but licorice can have a lot of interactions with antihypertensive drugs, so keep that in mind. What is a podiatrist? Pod, podiatrist? A podiatrist is a doctor of pediatric medicine, a physician or surgeon that treat foot, ankle, and related structures of the leg. And usually you consult a podiatrist for diabetic patients to check their feet. Wound adhesions. Wound adhesion is a surgical complication in which the wound ruptures along the surgical incision, as you see in the picture. Keloid, you need to know the definition, are raised overgrowth and scar tissue that occur at the site of the skin injury, as you see in the picture. CPAP, familiarize yourself with it, read the notes for the definition of the CPAP. Lab values, we're going to go over this. Creatinine, same as lithium, 0.6 to 1.2%. INR. Patients on warfarin, you need to monitor their INR. Usually, our therapeutic range is 2 to 3 times the normal level, so which is 2 to 3. Anything above 4, you hold the medication. You look for signs of bleeding. You prepare yourself to give vitamin K, and you call your physician. PTT normal is 30 to 45. If patients are on heparin, your target is 2 to 3 times the baseline, which is the 30 and 45. So 2 to 3 times that. Again, if your patient is having any signs of bleeding, you halt, or if it's more than 2 to 3 times the baseline, then you hold the medication, assess for signs of bleeding, prepare to give protamine sulfate, and call your provider. Potassium normal level is 3.5 to 5.3. And low potassium, you hold any medication that causing low potassium, like Lasix. You assess the heart, you prepare to give potassium, and you call your provider. High potassium, you hold any potassium-sparing diuretics like aldactone. You assess the heart. Usually you perform an ECG, prepare to give dextrose with insulin and Kexalate, and notify your provider. Potassium higher than 6, then definitely they're going to ask for an ECG, assess the heart, hold the medication, and call your provider. BUN from 8 to 30, that's the normal. You can say 10 to 20. You can say 8 to whatever, 10 to 30. If elevated, it's a sign of dehydration. Serum, so this is bicarb, 22 to 26. If abnormal, it's not a big deal. Hematocrit, it's 3 times the hemoglobin. Keep that in mind. Oxygen saturation is 95 to 100. A little bit about mechanical ventilation alarms. High pressure alarms means that there's an obstruction or increased resistance somewhere. What to look for? You look for kinks in the tubes, water collection in tubes, mucus plugs. Unkink the tubes if they are kinked. Empty the tubes if they have collection of water. Turn the patient, cough and deep breathe. If there's a mucus plug, you never pick suction over turn, cough, and deep breathe in the options. So low pressure alarms, you're gonna look for disconnection in the tubing. So what you're gonna do is you're gonna reconnect. If the tubes are disconnected and they are below the bed level, basically you're gonna go call your RT and ask them to replace the tubes. In the meantime, you're gonna ambo bag the patient. Malignant melanoma, this is the characteristic of malignant melanoma. It has irregular circumference, so it's not like a perfect circle, and it has multiple colors in it, and it is elevated and hard. Kubler-Ross grief cycles. Familiarize yourself with those: denial stage, anger, depression, bargaining, and acceptance. Usually when you break down the news for a patient with a chronic illness or like cancer or something, then first they're gonna deny it, they're gonna get angry, they're gonna get depressed, they're gonna start bargaining, and then they will accept it and move on with the treatment. So you need to know basically with every stage what kind of approach you're going to use. So with the first 2 stages, you're going to use informational and communication strategies. The depression, you're going to show emotional support, and bargaining and acceptance, you're going to guide the patient and direct them towards the treatment and proper care. So 8 ethical principles that you need to familiarize yourself with. I'm not going to read the definitions, but you familiarize yourself with them. Print the slide. Definitely print it. Beneficence, non-maleficence, and then you've got autonomy and confidentiality. You've got social justice. You've got procedural justice. You've got veracity, fidelity, and you've got paternalism, and you've got restitution. Okay, 8 of them. Familiarize yourself with them. Different scenarios. Electrolyte imbalances. We talk about kalemias. So if you have a hypo or hyper, it depends. So that's the prefix. The patient will go in the same direction as the prefix, except for the heart rate and urine output. We explained this before. Just memorize it that way. So if it's hyperkalemia, then excitatory symptoms with bradycardia and low urine output. Hypokalemia is the opposite. It's inhibitory symptoms with tachycardia and high urine output. Calciums are the opposite. So the patient goes opposite to the prefix. So you need to pay attention for hypocalcemia signs and symptoms like Fosdick signs and Trousseau signs, and you need to know how to test for those signs. Note, if skeletal muscles or so if the scenario is talking about skeletal muscles or nerve, always blame the calcium. So hyponatremia indicates dehydration. Hypernatremia indicates dehydration. Hyponatremia indicates fluid overload. Note, if you have a debate, never pick up magnesium. Never, never, ever pick magnesium. So we already talked about autonomic dysreflexia. We're going to skip those. And noxy stimulus, we talked about this. I have the slide. Oh, wait a second. So visceral organs are internal organs like the pancreas, the heart, the intestines, the liver. Internal organs are called visceral organs. So I just want to make sure that I highlight this. If you find a patient unconscious before you start CPR or check for airway, breathing, or circulation, you call for help. As soon as you verify that the patient is not conscious, you call for help, and then you go ahead with your ABCs. Hip abduction pillow with patients who have total hip replacement. Just familiarize yourself with it. This is how you place it. Chest inspection. So chest wall, whenever you're doing physical assessment, so a chest inspection, you inspect wall abnormalities. So there are chest abnormalities like kyphosis, which is abnormal anterior posterior curvature or curvature of the spine. We're going to see a picture. Scoliosis is abnormal lateral curvature of the spine. Barrel chest, you see it with COPD patients which is increased anterior posterior. It's normal in children to have barrel chest, but in COPD patients you'll have that barrel chest. And we're going to see it right here. Look in the second picture right there. So how do you perform chest percussion? So if the sound is dull, then you are over a bone or an organ. If the sound is not dull, is light, then you are over a lung, like you are over air or something. Okay. So tactile fremitus. This is how you assess for pleural effusion, consolidation, or pneumothorax. So if you put your palm on the patient's chest and you ask them to say 99, if the vibration is increased, then there's a sign. That's a sign for consolidation in the lung. If the vibration is decreased, then you think of pneumothorax or pleural effusion. Anorexia nervosa. Well, anorexia nervosa is a clinical syndrome in which the client has irrational fear of weight gain, preoccupation with food, a very restrictive diet, refusal to eat, disturbed body image. Normally, fat reserve and muscle tissues are burned during periods of reduced intake. So usually the patient will lose sugar in the blood, then glycogen in the liver, then they will start losing fat, and then at the end they start wasting muscle. They will start using the muscle as fuel. Anorexia nervosa is the illness of the mind. So we're going to talk a little bit about the kids' toys. Kids' toys, 3 questions you need to ask when it comes to kids' toys. Is what you're doing safe? Like is giving this particular toy to the patient safe? Is it appropriate for that age group? Is it feasible? Can I bring it into the patient room? So let's talk a little bit about kids' toys. What do you need to know? Is what you're doing safe, right? That's a question you need to ask. No small toys for children under 4 years old. No metal toys if oxygen is in use. Be aware of fomites, and these are toys that can hold microorganisms. you need to stay away from them. And these are like stuffed toys are fomites. So also stuffed toys are considered push toys. Hard plastic action figures, they are washable toys, and you can take those into rooms with patients who have immunodeficiency. So kids toys, is it age appropriate? That's a question you need to ask. Just bear in mind, 0 to 6 month old, they can use musical mobile, but after the age of 6, you cannot use it, just for the fact that the baby might strangulate themselves. All right. So by the age of 6 to 9 months, cover and uncover toys, peekaboo with a blanket, books with windows, wooden toys are suitable for this age group. 9 to 12 month old, verbal toys, wooden blocks, to encourage, like speaking and, mumbling and stuff like that. Kids toys 1 to 3 years old, push pull toys like a wagon or a popper, like a ball popper. 3 to 6 years old, preschoolers work on balance like bicycle, cooperative play, like and pretend. So like pretend like you're a cop or whatever. Ages of 7 to 11 years old, these are school-aged patients or kids. Creativity, give those kids like blank pages and color pencils. They are competitive to play. Collective hobbies like Pokemon cards and stuff like that, my son loved those. Age group of 12 and 18, these are adolescents. Patients, in a hospital, if they are adolescents, they want to hang with each other in one of the rooms, then let them. Do not fight that, unless the patient is fresh post-op, or the patient has a contagious disease like TB or RSV or something. So gastric cancer risk factors, real quick. Risk factors for development of gastric cancer include chronic inflammation of the stomach, a diet high in salt, smoked or pickled food, genetics, of course, smoking, uh, pernicious anemia, which is B12 anemia, B12 deficiency anemia, gastric ulcers resulting from the bacteria H. pylori, and let's see, herbal remedies such as, so remember those plants: black kosh, blank kosh, black kosh, dong quai, red clover, ginseng, and more. Used in management of menopausal symptoms such as, may cause hypotension, actually, especially if you use them with antihypertensive drugs. So when using with antihypertensive drugs, so the use of this herbal product can affect blood pressure and circulation, so you literally need to be careful. Maslow's hierarchy of needs, you need to familiarize yourself with it. It always starts with physiological needs. You address breathing, food, water, shelter, clothing, and sleep. And then you address safety and security, love and belongings, self-esteem, and then self-actualization. So dust mitts, actually, these are filthy, dirty organisms. You can find them in fabric, especially with bed mattresses, and this how they look like. They're filthy, gross. And bunk beds, this how, so basically a patient with asthma sleeping on the lower bunk bed, they will get triggered every single day with those dust mitts, and they will have exacerbation every single day, and will keep going to the ER, for asthmatic attacks. So epiglottitis, real quick, we already talked about it. We touched a little bit about it earlier, but definition: epiglottitis is an acute inflammation and swelling of the upper region of the throat. Signs of respiratory distress include dyspnea, chest tightness, decreased saturation, wheezing, and diminished air movement. Nursing care plan for those type of patients: think ABCs. Like, you need to really think ABCs: airway, breathing, circulation. SpO2 should be monitored to assess effectiveness of respiration, fluid replacement, and antibiotics to treat the infection. Because by the end of the day, it's epiglottitis, infection or inflammation of the epiglottis. Actually, this is a picture of the epiglottis. You can see it right there. It's numbered 3. 3, that's the epiglottis, and that's another picture of the epiglottis. It's inflamed, it's huge, and it compromised the airway because you can see an ET tube over there. So diverticulitis is another GI problem, another GI disease definition. It's an inflammation or infection in one or more small pouches in the digestive tract. I'm going to show you a picture. That's a picture of a colon, and it has those small pouches where food will sit there, and then over time it will cause infection. This is another picture how they look from outside the colon, from the peritoneum view. These are labs. We went over them. Just make sure that you know them. That's the only slide you need to know. We're going to talk about ego defenses. Ego defenses. Freud once said, life is not easy. The ego, the id, sits at the center of some pretty powerful forces. So the ego sits at the I, not the id. The ego, the I, sits at the center of some pretty powerful forces. Reality of society as represented by the superego, and biology as represented by the id. And the biology are the desires and the things you love and stuff like that. So when the ego gets stressed, anxiety builds up, and the ego unconsciously employs a range of defense mechanisms. Those defense mechanisms could be repression, denial, projection, displacement, regression, sublimation. And we solved questions regarding those, and I have a table here for you that explains every single one of them and give an example of every single one of them. So I beg you to print this up, to print the slide out and hang it on your study wall or in your notebook, and make sure that you are familiar with it. Again, medical terminology is key on the NCLEX, so you need to know what cloasma is. Chloasma is discoloration or hyperpigmentation of the forehead in pregnant women, and the linea nigra is that line on the umbilicus course towards the symphysis pubis where it is obvious during pregnancy. We're going to talk a little bit about antibiotics, and the most common, most important antibiotic family is aminoglycosides. We refer to them as mycins. Gentamicin, streptomycin, neomycin, kanamycin, tobramycin, and these are some really powerful antibiotics, and they treat some really dangerous infections. Trust me, any infection that has to deal with gram-negative cocci, gram-negative rotes, E. coli, MRSA, I mean, you name it, you need to give that patient mycins to treat that type of infection. There are some medications that end with mycin, but they are not used to treat serious infections, and they have the word throw in the middle of them. So not a mycin, like it is a mycin, but it's not a mycin that treat serious infection. So like azithromycin, zithromycin, and clarithromycin. So a little bit about these aminoglycosides side effects. They cause neurotoxicity and nephrotoxicity. So neurotoxicity, they affect the cranial nerve 8, which is the vestibulo-ocular nerve, manifested by ototoxicity. So the signs that you might see are tinnitus, unilateral or bilateral, hearing loss, dizziness, lack of coordination and movement, unsteady gait, and bouncing vision. These medications are given every 8 hours, IV or IM. And like relate the 8 hours to the cranial nerve 8, and then you would memorize that vestibulo-ocular nerve. So it's 8 and 8. Nephrotoxicity, best indicator of kidney function is creatinine and 24 creatinine clearance. BUN for dehydration, as always. Oral aminoglycosides are only used in 2 cases, and 2 cases only. The first case is the hepatic encephalopathy or hepatic coma or liver coma, where the ammonia will build up in the blood, and it will cause to basically kill brain cells. Oral mycins kill the E. coli in the gut, and the E. coli are responsible for building up ammonia. So another tip for patients with liver disorders and hepatic disorders, you stay away from eating a lot of protein, because protein are metabolized into ammonia. So try to stay away from protein. protein diets. Don't choose that in your selection. So we said 2 cases. The first case was this case. The second case is pre-bowel surgeries. So pre-bowel surgeries, the surgeons like to give oral mycins to sterilize the bowel and again to kill the E. coli. This slide is about hyperglycemia. So hypoglycemia. Hypoglycemia signs and symptoms are excessive thirst, hunger, frequent urination, dry skin, blurred vision, drowsiness, and nausea. And I have other flu slides that will explain hypo and hyper in a very nice way. Again, medical terminology is key. Agoraphobia. Agoraphobia is the abnormal fear of being helpless in situations from which escape may be difficult or embarrassing and is often characterized initially by panic or anticipatory anxiety, and finally by the avoidance of open or public places. So patients with agoraphobia, if you put them in those kind of situations, they will get violent, right? So you need to be careful. We're going to talk a little bit about signs of dehydration. They are thirst, decreased urine output, dry mucous membranes, poor skin turgor, weight loss, hypotension, tachycardia, and lethargy. Please familiarize yourself with these basic signs and symptoms of these basic situations like dehydration, fluid overload, stuff like that. They are very important during your NCLEX. We're going to now talk a little bit about breast self-examination. Begin by looking at your breast in the mirror with your arms on your hips, then move your arms above your head and observe any changes and abnormalities. When we talk about abnormalities, we talk about lumps, asymmetry, and anything abnormal, basically, anything abnormal in structure. Observe the nipples, look for any discharge, bleeding, inversion, or dimpling. Lie down and use your right hand to feel your left breast with the first few fingers. So pad on the hand. Fingers should be kept flat and together and should be firmly touching the breast in a circular motion to assess for any lumps or lipomas. Repeat the step for the other breast. Some clients prefer to test their breast under the shower because the skin would be slippery, and that's perfectly fine. Some acts that you need to memorize for your NCLEX, there are only 4 of them. Of course, there are hundreds in healthcare, but for your NCLEX, the nursing board would like you to know 4 act violations. Be careful of the Patient Self-Determination Act, which is the lack of information regarding advance directive. Every time the patient comes into the hospital, you need to review the advance directive with them. EMTALA is the Emergency Medical Treatment and Active Labor Act. Failure to provide medical screening examination to determine whether emergency medical condition exists or not. It's very important not to violate this. And then you've got the HIPAA, which is unapproved sharing of clients' information. And you've got the National Organ Transplant Act, where people privately sell their organs. Kaposi sarcoma, we already touched on this earlier. Varicella zoster virus. Varicella zoster virus is the cause of chickenpox and herpes zoster, also called as shingles. Chickenpox follows initial exposure to the virus and is typically relatively mild. Self-limited childhood illness with a characteristic exanthema contagious viral rash. Okay, whenever, with the chickenpox, whenever the papules they have a fluid in them, then they are contagious. But if they dry up and they are crusted, then the chickenpox or the varicella is not contagious anymore. So that's a key to know. If the papules are crusted, then it's not contagious anymore. If they still have fluid in them, then they are contagious. Candidiasis, or Candida albicans, these are fungal infection in the oral mucosa. Infection caused by yeast that belong to the genus Candida. There are over 20 species of Candida yeast that can cause infection in humans. The most common of which is Candida albicans. It develops yeast infection of the mouth, esophagus, and vagina. And in the mouth, they look like that. This is a severe case, obviously. but there are some minor cases where you see white material on the tongue and the buccal area. Herpes simplex type 1, which is contagious through touch. Uh, they are caused by herpes simplex virus. There are two kinds: herpes simplex 1, which is usually not sexually transmitted disease, while the HSV2 is a sexually transmitted disease, and it's herpes on the genitalia. All right, so both viruses can be transmitted by saliva, body secretions, or oral sex. They come in clusters, usually clusters of vesicles, and as you see in the picture, they look like that. Lanugo actually is the fine and soft hair, especially that covers the body and limbs in a fetus, in a newborn, and they go away after 2 to 3 months. We've got the creases, elbow creases contain vernix, uh, protective cheesy-like gray-white fatty substance on the skin folds under the arms, elbows, groin, scrotum, and labia. Use baby oil. Do not attempt to remove vigorously. So do not attempt to remove them. You will mess up with the infant's body temperature, and you will cause them severe hypothermia. You want to stay away from that. And I just want to shed some lights on the halo vest traction. Halo vest traction, you use it for patients who have fractures in their spine. So this is how it looks like. And the hip spica cast, it looks like that. It could be a bilateral long leg hip spica cast, or it could be 1.5 hip spica cast. All right, the genital area is always exposed for the patient to do their business. I just want to differentiate between the continuous ambulatory peritoneal dialysis. The continuous is the one that you install the dialysate for like 3-4 hours, and then you come back after 3 and 4 hours, and you remove, the dialysate. You drain it from the peritoneum, and then you install new dialysate again in the abdomen. The automated peritoneal dialysis is the one that you hook your catheter, peritoneal catheter, to a machine during the night, and you perform dialysis all night long while sleeping. So things that you don't want to do with alcohol: you do not want to mix medication with alcohol. You do not want to drive cars or operate heavy machinery while you are under the influence of alcohol. You do not want to be responsible for the care of kids under the age of 12. So babysitting is prohibited. We're going to talk a little bit about anticoagulants. We're going to talk about heparin and Coumadin. You're going to get tons of questions about those. So route of administration, onset, treatment period, antidote, monitoring, and pregnancy. The route for heparin is usually IV or sub-Q. For Coumadin, it's PO. For heparin, the onset is immediately, right away. For Coumadin, it takes 3 days until it stabilizes in the patient's circulation. Treatment period is usually 21 days. Then they switch to low molecular heparin, which is the Lovenox. With Coumadin, it's a lifelong treatment. The antidote for heparin is protamine sulfate. For Coumadin, it's vitamin K. Things to monitor are the PTT. With the Coumadin, you monitor INR or PT. Heparin is safe during pregnancy. It's class C, while Coumadin is unsafe during pregnancy. And I put here an FDA drug risk classifications for drugs as per categories. So please print this out, take a look at it, try to understand the different categories, and what are the drugs that are not safe in pregnancy. You don't have to memorize every single drug, but at least the drugs that we discuss here on the webinar, memorize them, like the antiglycemics or Coumadin. Let's see, substance abuse or substance use. There are two families or two categories of substance use or abuse. You've got the uppers and you've got the downers. Okay, uppers that will have excitatory symptoms, like everything excitatory. The patient is hyper. So these are the people who are consuming substances like caffeine, cocaine, PCP, LSD, hallucinogens, so they cause hallucinations, and methamphetamines, ADHD drugs like Ritalin. Downers are like everything else, like heroin, alcohol. They are downers. They cause the patient to like go to sleep, be like stoned, drunk-like symptoms. So this is the abbreviation for LSD and PCP. These are the drugs. Familiarize yourself with them. So signs and symptoms for substance abuse. So if we're talking about upper substances, then everything is excitatory. Everything goes up, like if euphoria, tachycardia, tachypnea. Patient will be restless, irritable. They will have diarrhea, borborygmy, which is increased intestinal sounds or abdominal sounds, seizures, +4 reflexes. Remember, the normal reflexes should be at +2. Above that, they are hyper reflexes. So the downers, everything is inhibitory, everything is down. The opposite to uppers, patient will be most so you will be most worried about respiratory arrest. That's why you get your equipment that are necessary for respiratory arrest or seizures. These are the things that you need to make sure that you cover, with your patients. So I put the slide out here just to explain or just visualize the tentorium. Where is the tentorium? It's the line that separates the cerebrum from the cerebellum. So I just thought I'll throw a picture right there, because sometimes they talk about supratentorium bleed, or supra or supra, so above the tentorium. All right, infratentorial bleed or something. All right, so treatment for potassium imbalances. How do I treat hypokalemia? Usually I give potassium, never, 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 ever IV push. Orders to questions the provider on the test. So yeah, like which order to question on the test. Do not give more than 14 mg of potassium in a liter of fluids. Okay, so that's an order that you need to question on your NCLEX. Treatment for hyperkalemia is usually D5 water and insulin. The insulin of choice for IV is Act Rapid or R, insulin R. Insulin usually opens the door for potassium to get into the cell. You can give Kegsalate to lower potassium via NG tube, oral, or enema, but that takes at least 2 hours to lower, your potassium. Some pro tips with electrolyte imbalances. Always choose in, like SATA questions, paresthesia, which is numbness and tingling, paresis, which is muscle weakness. Always select paresthesia and paresis and select all apply questions. That's just a pro tip. This is the Blackmore tube that I talked to you about earlier. It's used for esophageal bleeding or gastric bleeding. You just inflate those bad boys and they will take care of the bleeding and will shut it down. So it's like the esophageal gastric tube, same thing. So antisocial personality disorder, people with antisocial personality disorders tend to antagonize, manipulate, or treat others harshly and with callous indifferences. Um, they show no guilt or remorse for their behavior. Individuals with antisocial personality disorders often violate the law, becoming criminals, and it's very hard for those patients to become normal people. They will keep and manipulating for the rest of their life. So laryngectomy, I just want to throw a picture out there for the laryngectomy. I mean, a patient could have a laryngectomy without a tube present in place. So it's just the stoma over to the larynx, and then you suction the stoma with a suction catheter. Okay, always when you go in the tracheostomy or the laryngectomy, stoma or tube, when you go in, you do not suction. You only suction when you on your way out. The yanker, you don't use it for the stoma. You just use it for oral suctioning, like in patients who experience, what do they call it, who experience seizures. After seizure, you need to suction any gastric material that came out of their stomach. Extrusion reflex actually is a normal reflex in patients below 4 months old, and by 6 months it should disappear. Infants use this movement of the tongue as a normal reflex when anything touches their lips. It helps with sucking from a breast or a bottle. Babinski sign is actually, so if it is positive in an infant less than 1 year old, then that's normal. The toes will flare, and that's normal. But above 1 year old, the toes should flex instead. Should flex, yeah, instead of flaring. Okay, tripod position is actually this position when you put both hands on both knees and lean forward a little bit and try to deep breathe. Most common among COPD patients, asthma patients, patients with pulmonary edema, patients with severe respiratory distress, pregnant women, you name it. Any patient with respiratory problem, that's the most comfortable position that they can be in. I just threw this picture here to tell you that, like sweet potato, they have very high protein component to it. So they have carbohydrates of 26 grams, but still like they have almost 13 grams of protein. So sweet potato soup or potato soup are actually high in protein. I just want to touch on Bell's palsy and trigeminal neuralgia. So Bell's palsy is a neuromuscular disorder, and you can read the signs and symptoms that you see, but most importantly, I want you to know that treatment for Bell's palsy is to give steroids, okay, to give IV steroids. While in trigeminal neuralgia, you do not give IV steroids, okay. And with both diseases, you do not massage the cheek. So if they tell you massage the cheek to relieve the pain or anything like that, you do not do that. You do not even come close to it. Of course, when you eat on the other side, on the unaffected side, and you try to perform oral hygiene frequently just to make sure that you are not increasing or you're not putting yourself at risk for infection. So the next slide is the meniscus tear. This is very common among athletes. They will have this tear during, training and whatever. So I just want to throw this picture out there so that you will have a photo memory of the meniscus tear. This is the JP where you spoke about this. The ET tube, I just want you to know that, the pilot balloon is the balloon you install the air in so that the cuff is inflated. Okay, just want to throw this out there. Some might be confused with the pilot balloon and the cuff, but this is the anatomy of the ET tube. Regarding Glasgow-Coma scale, I mean, you can read through it. You can learn more about the Glasgow-Coma scale, but what I literally want you to know is anything below 8, that means that this patient is not breathing properly. So if patient has a Glasgow-Coma scale score below 8, this patient needs intubation and needs to be sedated and taken care of, okay? And if you read down at the bottom, minor brain injury are patients who score between 13 and 15. Moderate brain injuries are patients who score between 9 and 12. Severe brain injuries are patients who score between 3 and 8. And I just want to touch on Paget disease. Paget disease is a disease that disrupts the replacement of old bone tissues with new bone tissue. Paget's disease of bone most commonly occurs in the pelvis, skull, spine, and legs. Risk factors include increasing age and a family history of this condition. Over time, affected bones may become fragile and misshapen. And usually, like bone growth it's like the bone tissue is growing in places that it should not grow. Okay. And I just want to touch a little bit on the alliginated dressing. This how it looks like. You use it with wounds or pressure ulcers that have exudate in them. So this is a way to absorb the exudate and maintain good healing process. Addison crisis shock. So I should have put this slide with the Cushing syndrome and the Addison disease, but anyway, Addison crisis shock. The signs and symptoms that you see with the Addison crisis, or they call it Addisonian crisis, severe vomiting and diarrhea leading to dehydration, low blood pressure, hypoglycemia, hyponatremia, and hyperkalemia. You will see those. Treatment usually is steroids. So Addison disease is low cortisol levels, so you just replace that cortisol with prednisone or dexamethasone. Alrighty, so let's see. So I believe this is the multiple sclerosis. A definition is it is a chronic, typical, progressive disease involving damage of the sheath of the nerve cells in the brain and spinal cord. So it will delay a lot the transmission of the message from the cell soma or the cell body towards the terminals or towards the dendrites. Some of the main symptoms of multiple sclerosis you can see in the picture, and you can read more about it, but I'm going to read a few. They will have optic neuritis, they will have diplopia, which is double vision, they will have dysarthria, dysphagia, they will have fatigue, depression, anxiety, unstable mood, they will have muscle weakness, ataxia, they will have paresthesia, they will have diarrhea, constipation, incontinence, and yeah, bowel incontinence and urine incontinence. So familiarize yourself with those. And we're going to talk later about, so multiple sclerosis, we're going to talk about myasthenia gravis as well and the difference between them. An ear exam in pediatric population, how do you test for it? You pull the pinna down and back to straighten the ear canal in children under 3 years old. So above 3 years old, you pull the pinna up and outward, which is completely the opposite. Up and outward to straighten the ear canal in children above 3 years old. So I'm not sure why I put this. Oh yeah, I remember. I told you guys I have two slides that will enable you. Like these are like algorithm. I'm not sure, but how to memorize hypoglycemia signs and symptoms and hyperglycemia signs and symptoms. So with hypoglycemia, it's the word tired. So T-I-R-E-D. T goes for tachycardia, I irritability, R restlessness, E excessive hunger, and D diaphoresis. So the patients will have cold and clammy, and they need a candy. Usually give simple sugar. Hyperglycemia, 3 Ps, polyphagia, polydipsia, and polyuria. Hot and dry, sugar is high. And when a patient is breastfeeding, usually if there is white material on the tongue, I don't want you to think about that this is milk, this is breast milk. No, this is thrush symptoms. These are candida on the tongue, needs to be treated. Okay, and we're going to talk a little bit about anaphylaxis, signs of anaphylaxis. We summarize them in this table right here. The skin, you're going to see hives, you're going to see itchiness, redness, swelling. Respiratory, you're going to see coughing, sneezing, shortness of breath, wheezing, chest tightness, throat tightness, trouble swallowing, hoarseness, nasal congestion, flu-like symptoms, itchy nose. I mean, you name it. With gastrointestinal, you're going to see nausea, vomiting, diarrhea, stomach pain, or cramps. Cardiovascular, you're going to see dizziness, lightheadedness, pale, blue color, which is cyanosis, weak pulse, fainting, shock, loss of consciousness, neurological. Patient's going to be anxious, feeling impending or doom, feeling that something really bad is about to happen, headache. And they will tell you that. They will become so irritable that they know something's going on, but they cannot tell what's going on. All right. So the difference between rash and hives, which is high, like a lot of people mix between the two. So this is the rash. It's like a red distribution of of rash. Hives are literally, they are hives, like this is how they look like. This is a very serious situation. Spinal cord injury. So when we talk about C4, they call it tetraplegia. A C6 injury, they also call it tetraplegia, but I just want you to know the difference. Like with C6, yes, it's tetraplegia, but you can still use the shoulder for some shrugging if you want to shrug, and you can still use the upper respiratory muscles like the apex of the lung. They are not paralytic as well. Okay, T6 injury, they call it paraplegia, same as L1 paraplegia, which is your lower limbs are paraplegic, and this is the level of paralysis, and just familiarize yourself with them. So here I just want to see, you know, sometimes when you insert an NG tube, it might go into the trachea in pediatrics and the patient will start coughing. What you need to do is you need to pull that tube a little bit up into the pharynx maybe. Let the patient take a few breaths, settle down before you try next attempt, okay? And you always ask the patient to swallow while inserting the NG tube. Gonna talk a little bit about skeletal tractions. Skeletal tractions, you know, if the femur is broken, then you're gonna find the skeletal traction at the patella area or the upper tibia, and there you'll find a string. It's pulling uh, distal to the patient's body, and you'll have weight. Usually, it's 7 to 15 kgs, depending on the fracture and the weight of the patient, of course. So skeletal tractions, it is a surgical procedure used for long-term management of fractures. And then you've got the skin traction. They call it box traction. It's not surgically put. It's used for temporary management of fractures, like in the field or in the ER or something. Myasthenia gravis is caused by breakdown in communication between nerves and muscles, and this is where the situation is that when the neurotransmitters come from the cell towards the muscle, they cannot stick on the receptors because those receptors are blocked. So symptoms, you can have ptosis, you can have drooping of one or both eyelids, you can have diplopia, double vision or blurred vision. You can have limited facial expressions because of, paralytic facial muscles. You can have dysphagia, dysarthria, which is slurred speech, and, weakness in your neck, arms, fingers, and legs. All right, so treatment for myasthenia gravis, there is actually no cure, but they use steroids. They use mestinon, which is very, very common. On your NCLEX test, you're gonna see this medication, mestinon. These patients should not take any quinolones. This family of antibiotics, the fluoroquinolones, they should not take it. All right, I have here immunization schedule for pediatrics. So just familiarize yourself with immunization schedule. Earlier on today's webinar, we said that Haemophilus influenza is only taken once. No, it's taken on multiple doses. So as you see here, it's taken on 2, 4, and 6 months, or maybe 2, 4, and 8 months. Actually 12 months. So 2, 4, and 12 months. Just make sure that you familiarize yourself. I don't want you to doubt yourself on your NCLEX, like the real NCLEX test. I literally want you guys to memorize it. So lactose intolerance or lactase deficiency is the inability to digest sugar. You need sugar, which is lactose. You need lactase enzyme to break down lactose into glucose and galactose. So if you do not have that enzyme in your intestines, then that is a problem. You will have lactose intolerance. So lactose is very common in dairy products, so stay away from it if you have lactose intolerance. So kosher meat is actually very popular among Jews. So it is the meat So the cow is slaughtered in a special way where you slaughter the cow and you hold the cow upside down with the head down, and you drain all the blood, from the neck outside of the body. And they only eat the first half of the cow, where you see in a picture the chuck, rib, plate, brisket, and chunk. So they only eat that part of the cow. The other part, they do not eat it because I believe it has like milk products to it or something like that. So kosher meat are those type of meat. They are the animals are slaughtered in a special way, and they are prepared in a special way. So here I put this picture just to touch a little bit on the beta receptors. So beta adrenergic receptors in the lung and heart. So beta blockers usually work on both. It could be beta 1 or beta 2. So beta 1 is in the heart, beta 2 receptors are in the lung. High potassium high potassium food, we have examples here like mango, orange juice, oranges, peaches, kiwi, bananas, prunes, raisins, all have dried fruit. They all are high in potassium, as well as avocado, like sweet potatoes, pumpkin squash, tomatoes. Just familiarize yourself. Like salt substitutes are very high in potassium. You need to familiarize yourself with those. So we're going to talk a little bit about mechanical ventilation modes. So the only two modes that I would like you to learn are the AC mode. What I want you to learn about the AC mode is that parameters are set in advance. It's completely controlled by the ventilator, and the patient is not allowed to take any breath on their own. So the inspiration is in green, expiration is in pink. So this is how the respirator is giving breath for the patient. Okay, so every 4 seconds, the ventilator is giving one breath to the patient. Let us say in the middle of them at 2 seconds, the patient took spontaneous ventilation. What will happen? The thing, if the patient took a breath, then the ventilator will take over and will not allow the patient to take a breath on their own. They will take over and give a full breath to the patient. That's why it's controlled, like so it is completely controlled by the ventilator. But the SIMV mode, which is synchronized inspiratory mechanical ventilation. I'm not sure about SIMV mode. So at 2 seconds, if the patient wants to take a breath, then the ventilator will allow the patient to take a breath on their own. And even though if it's not a full breath, but this mode is used as a weaning mode from a completely controlled mode to helping the patient to get into a place where they can extubate that patient. So SIMV mode is a weaning mode for patients. So this is if you want to compare AC mode to SIMV mode side by side. So a little touch on SIRS or sepsis, septic shock, stuff like that, the stages. SIRS, you need to have at least two of those criterias. High temperature above 38 degrees or lower than 36 degrees, heart rate of more than 90 beats per minute, respiration of more than 20, PaCO2 less than 32 millimeter Hg, white blood cells of more than 12,000 or below 4,000. You consider it sepsis if you have two of the symptoms above plus a focused infection. So let's say it could be a UTI or a pneumonia or infected wound or whatever the case might be. Severe sepsis is sepsis associated with organ dysfunction. So systematic hypoperfusion to the kidneys maybe, or hypotension, stuff like that. So septic shock is, so the patient is having hypotension. Even if you challenge the patient and give them fluids, they will not they will not react to that fluid replacement, and they will stay hypotensive. That's hypotensive shock. We're almost done, guys. I'm telling you, by the end of this webinar, we have some announcement that I would like you to know, take advantage of. So stay tuned, okay? We're gonna go through these slides very quickly, and day 20 is a way for you to review all the slides that you need to know for your NCLEX. So that's why we're going over them quickly, so that you can like tack, 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 tack. All right, the next slide is actually this is called Asian. Let's call it yeah, I believe it's called Asian coloration of the patient. Usually you see it among COPD patients. So if these patients turn pink when you give oxygen, then you better watch out, because those patients are about to have a respiratory arrest. Because these patients cannot turn pink, that's hyperoxygenation of COPD patient, which is not good. Some patients who have phobias of certain things, you need to use with them behavioral modifications. We're going to define systematic desensitization, which is behavioral modification. It's to provide the person with a very minor version of his phobia and work them up to handle the phobia comfortably. An example here is about snakes. So if a patient is afraid of snakes, you have them watch a short movie about snakes, then you have them hold a stuffed animal snake, then you have them hold a plastic snake, then you have them hold a glass container with a snake inside, then have them touch a small harmless snake, then gradually work to holding a regular sized snake. So this is actually a skin graft. This is an allogenic skin graft. So usually they skin graft, like this could be a burn or something. So they take a piece of skin from the patient's thigh, and they implant it here in the forearm. Usually those patients, you tell them you cannot move or aggressively use your hand for the first 3 to 5 days after the transplant, okay? Capillary refill, this is the way you pinch your nail until it blanches, and then you release, and it should get back to pink within less than 3 seconds. This picture is about eschar, where the patient had a burn and then they form an eschar, a circumference eschar, and it will cause the patient decreased perfusion on the periphery. So the physician will literally have to do something called escharotomy, where it's basically like compartment syndrome, where they will have to cut through the eschar from all the way from proximal to distal, just to allow the leg or the extremity to breathe and have proper perfusion. Cataract, so this is a healthy eye. So this is a clear lens, and a cataract is a cloudy lens. When you do cataract with lens replacement or lens implantation, you remove the cloudy lens and you insert a new clear lens. Cleft palate, patients with cleft palate, they cannot suck on. So basically they have problem with feeding. They will have special nipples that you will insert in their mouth, and it will drip directly into the esophagus. Usually those patients you do not introduce solid food until like they are 2 years old. Usually you perform surgery on them by the age of 18 months. You give time for that hard palate to heal, for the bone to grow, before you take the patient into surgery and perform surgery on them. So like basic information about cleft palate. So guys, that brings us to the end of day 20. That brings us to the end of the webinar. Congratulations, and I'm literally happy for you for completing this webinar. I cannot, I'm so humbled to tell you that it has been a great opportunity to share this experience with you. I hope you had insight about, you know, what's going on and what's going to happen on your NCLEX. Literally, if you follow what I say, if you hear day 20 over and over and over again, you'll get familiarized with the slides that you need to memorize. And I can't stress that enough. Keep solving those questions, you know, those 1,000 questions over and over and over again, because you're going to see similar questions on the NCLEX test. That brings me to my announcement. I'm gonna share my website with you guys. This is the website, and I'm gonna actually, let me see, let me grab the chat right here. Where's the chat? Okay, let me grab the chat right here. I'll take it to the other side. And I'm not sure what's going on, but okay. So I'm gonna drop this link down there. It's not dropping. Okay, so basically, this is what I want to share with you. I was, you know, someone introduced me to a professor who used to write for the NCLEX boards, write questions for the NCLEX board, and he is an amazing man. He just got into retirement last year, and literally that's the dude you need to talk to understand NCLEX and what the Board of Nursing would like to know from, you know, new nurses in the United States and how to practice safely. So after our second time we sat together, I was telling him about, you know, what I was doing, you know, creating this business, helping other nurses pass their NCLEX. And we went into discussion, like we were going into discussion of how he write questions and what does the Board of Nursing need of him, need of the nurses. And then we like collaboratively work together on writing NCLEX like questions, you know, me and him. So actually he wrote them, but you know, I like finalized what are the things that I need, what are the things that I can explain on my own, like I can have my own version of them, and what are the things that are new that I've never seen before, but they are very common on the NCLEX, different strategies. So I ended up, you know, working with this guy, and you know, we bought, I mean, actually I bought, this is the guy actually, I bought those questions from him, and literally I'm selling them to you guys, but it's not about the money. Again, it's about, you know, the value that I'm providing. Basically, I bought this these questions, you know, from this professor, and I mean, one way or another, I want to collect my money back, but that's not the thing. So if you go to the website, this is the website. I couldn't drop a link here. I'm not sure why, but I couldn't drop a link. But this is the link right here. It's nclexwebinar.com/nclex hyphen exam or dash exam slash. If you go to the website right here, then you can land on this page, and so you can purchase one question, one sample, and I believe it's for $19.99. And if you want to go ahead and purchase 3 tests, which is a bundle exams, you can purchase 3 tests for a reduced price. And with this package, you not only will get the 3 tests, but you will get a bonus, which is slides from day 20 webinar. So you'll get all those slides. They are around 290 slides. You'll get them in one email all together, instead of you like printing them from 20 different webinars. And I will give you 20 tips or rituals that you must do on the day before the test and the day of your NCLEX. And when you go to the test center, when you take your breaks, you know, how to deal with first 10 questions, how to deal with your whole NCLEX. So literally I have not just 20 tips, more than 20 tips that I can offer you guys, that I will offer you guys as a bonus if you purchase the 3 test webinar. So I hope you will take this. If you don't want, you just want to test it, you want to take one test, just go ahead. But literally what I want to tell you guys is that those questions are written in a way that I mean, you're gonna see the same questions on your NCLEX. They will boost your chances to, you know, pass your NCLEX, to get familiarized with recently how NCLEX questions are being written, and how to answer them. Basically, you will get not only the correct answers with those samples, but you will get the rationale as well to know behind the scenes, like why this question was answered this way and what's the rationale behind it. So so that's the link again. It's www.nclexwebinar.com/nclex-exams. So go check them out. If there's anything you like, if you think that you're gonna find value out of those, then go ahead and purchase them. And yeah, I mean, it has been a pleasure. I literally love every single one of you guys. You have been tremendously uh, uh, like 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 you were giving it your best. You gave it your best, like hard work. Like you've been asking me questions, you've been asking for help, you've been asking for notes, for webinars, for slides. You guys have been so interactive, and I'm so glad that I had in my webinar. So we're gonna stay friends forever. If you decided to go ahead and purchase those, that's totally fine. You won't be able to find this page unless you type the whole thing. So if you type like NCLEX webinar, no one will be able to find this page. Actually, this page is only for those who complete the NCLEX and who attend day 20. And that's all I want to say. I will wish you all the luck in the world. I hope that you will pass your NCLEX. I have no doubt. And I hope when you pass, like when you sit for your NCLEX, just give me a holler. Let me know that you're sitting on this day or that day when you book your exam. And if there's anything I can assist with, please do not hesitate to text me. And let me know when you pass. Let's do that. When you sit for your exam, let's go ahead and do that pop-up. And if you do pass, we'll celebrate together. And then I mean, basically you will give me that 1-minute video, which is I'm so looking forward to, just to motivate others, just like the way you were motivated and you jumped on this webinar. All right, that's all for today. That's all for this webinar. It has been a pleasure. I mean, I'm gonna click that sign out and there are tears in my eyes. I'm so sad that this is over, but I'm also looking forward for the next webinar to help another group. We already have tons of students, so I'm so eager to go ahead and help another group all the way from scratch, from day one, and start the process all over again. As always, thank you for giving me this opportunity to help you through passing your NCLEX, make a difference in your life, make your dreams come true. I love your faces, literally. It was a pleasure meeting you, knowing you. Please, if you appreciate this webinar and you have friends who are sitting for this webinar, your word of mouth is my oxygen. If you refer your friend to this webinar and tell them that I attended this webinar, it's of great value, then you would not only be doing me a favor, but you will be doing your friends a favor. And in general, you'll be doing the world a favor when you're trying to help someone else to fulfill their dreams or find a solution to their problems and move forward in life. Alrighty, so until next time, our roads will cross, our path will cross. If you are by any chance here in the United States, let me know. In the next couple of years, I'll be traveling a lot, so we will meet somewhere and we will share this experience. We will talk about the past and the future and all the passions in between. So until next time, love your faces and good luck.